Okay, so you talk about the seal, you talk about leaking, you talk about resistance when you actually back the patients and all those things. And difficult SGA will be many attempts, either with or without tracheal abnormality. And laryngoscopy, so they actually break down into various aspects of your airway maneuvers, different aspects. So they give you the kind of definition. And what I like about thinking about airway difficulty is you have a range. You've got somebody who's got zero difficulty, natural airway, so no problem. And this one is in terms of mask ventilation. So as you go along, it becomes more and more difficult. You need one person, here you need two person, and then that's impossible. Okay, same with the laryngoscopy and intubation. So one attempt, and then multiple attempts, and then you've got other things that you need to do, and also you end up with impossible airway. And of course, sadly, if you reach that situation, you might end up with somebody with brain damage or death. Okay, so I think this is a very good diagram to represent the range of difficulty in difficult airway. Something for you to remember lah. Okay, so I won't go through this one, optimal position. I think all of you know the sniffing position and all that. So basically, you need to just align the axis, the oral axis, the pharyngeal axis, and what is it? Laryngeal axis. Yeah, thank you very much. So you can forget about the rest and be able to describe the ramping position. I asked my junior MOs, how do you ramp? What are you looking for? People give me all sorts of funny answers. But basically what you want to do is to make sure your ear to sternal notch is in the horizontal plane, isn't it? That one everybody knows? Yes? Yes? Okay, fine. You guys are ready to be specialists already. Okay, airway assessment. So how would you carry out a pre-op assessment of the airway to identify potential difficulty? A medical student will straight away jump to Malampati. I hope you don't do that, okay? So what I want you to do is to give me an answer in a very systematic manner, okay? Many guidelines can be confusing. You need to adopt your own system of how to assess a difficult airway. Okay, who can do that for me? Let's see. Ai-Sin Ling, are you here? You're here, okay. A very wide topic. Everybody can hear her? Does she need a mic? Okay, huh? All right.
Any mess of obstructing the airway or any difficult in opening mouth. And then further I'll go just look at the Malapati. And then after that I'll assess the thyroid mental distance, mental health distance, and also neck movement, any restrictive neck movement.
Okay. Somebody next to her, can you answer? What has she left out? Yes. When you ask about pre-op assessment, don't straight away jump to examination. You actually need to give the history. You need to do the examination and need to tell me about investigation. So what you gave me is just 1/3 of it. So you actually need to start from the beginning. Yeah. Okay.
Ask for history, whether any previous history of difficult airway, and then previous history of anesthetic concern, whether during the intubation any airway adjunct need to be extra airway adjunct needed.
Okay, let's say if the patient has never had a GA before, so what else can you ask about?
Does she has any medical problems such as pneumothorax arthritis, and also any cervical spondylosis, and or OSA, whether have any obstructive features like thyroid problem, and
okay.
Then after that, After that, we will see, like what she said, from externally. We can examine whether any predictors that can anticipating.
I think the examination part is fairly okay. Need a little bit more to pad up, but otherwise it's essentially that. Investigations?
Investigation, we can see from X-ray. X-ray, any trachea deviation or any narrowing of trachea, or CT, see whether any retrosternal extension.
Need to be specific. Yeah, exam need to be specific about which part of the X-ray, which part of the CT you're doing. If you tell me X-ray, it can be X-ray of the kaki. Okay, so you talk about neck X-ray or chest X-ray. If you want an AP lateral view, you just mention it to the examiner. So similarly for CT scan also, you're actually talking about the
Neck.
the neck and the thorax, isn't it? Okay, yeah. Sorry, I hope you don't mind. I just correct you along the way. It is so exercise to prepare you for exam. It's not to belittle you or to laugh at you. Yeah, okay. I hope it's okay with everybody. Okay, fine.
And any ENT entry regarding the vocal cord assessment?
Yes. So ideal finding is very essentially part of the examination. So basically, if the patient has got laryngeal pathology, you want to see the site, the size, the friability of the tumor. You want to look at the vocal cord function, whether the recurrent laryngeal nerves are involved or not, things like that. Yeah, very good. Okay, so so this is the very systematic way to me I mean, you actually need to go through the history, the examination, investigations, just like any other pre-op assessment. Okay, so whenever you have conditions associated with airway problem, patient is obese, patient is pregnant, patient has got cervical problems, patient has got connective tissue disorders, patients who've got upper airway difficulties and all that, that should ring a bell, okay, about possibility of difficult airway. Then you go through the past history. If the patient is a tumor case, whether the patient has had radiotherapy to the upper airway, to the to the oral cavity and things like that. Radiation fibrosis itself can actually make you have got problems with TM joint, for example, and things like that. So any history of difficult airway, past GA if available, okay, how difficult it is, how to overcome the difficulty, etc. Examination, again, you go back to the physical, the general status of the patient, whether the patient is obese, whether the patient has got short neck, whether the patient has got funny face, whether the patient is having stridor, obviously evidence of upper airway difficulties and things like that. Or do very systematic examination. Either you want to talk about the mouth first or you want to talk about neck first. Basically, these are the two things, isn't it? So oral cavity, open the mouth, see whether there's problems with TM joint movement, look in the oral cavity, see whether the tongue is big, look at the dentition, look at whether the patient has got buck teeth, whether this patient has got loose teeth, etc., whether there's an oral tumor, how big is it, is it obstructing the airway, look at the tonsils, etc., etc. So there's oral cavity. Very easy to remember that way. And then you talk about the neck, whether there's any mass in the neck, whether there's the range of movement is full, whether the patient actually have got any known cervical problem that limits the makes it impossible or inadvisable to move the neck. So you have to keep the patient in neutral neck position. And then you look at all this TM, the thyromental distance, sternomental distance, blah, blah, blah. So you can cover everything once you're systematic. You won't forget things, okay? And investigations, IDL scope is important. CT and MRI findings is also important. I forgot to put in X-ray, like simple X-ray, okay? So I've got all these things in various slides, so you can go through it at your own leisure, okay? Also, if you have time, you can look at this airway assessment booklet produced by the ANSCA. Okay, the web page and all those things are there. You can assess that. Very worthy. I think there's about 60 over pages and things like that. For those of you who are going for exam, you probably won't have time. But essentially, they're telling you the same thing that we are telling you now. So they actually group them into nice tables for you to just look through. But for me personally, I actually don't get very much more information from that lah. If you actually can stick to your own system, I think that's fine. Okay. So they actually talk about all these things, give you a lot of questions, and then see whether it sort of correlates with a difficult airway. They also put in things like aspiration risk and also any problem with the CVS recipe. Obviously, you need to actually think about all those things when you're talking about the patient as a whole lah. Okay, and also extubation problems and things like that. So it's good, but if you are actually studying in a hurry for exam, you may not want to actually do all these things, because all these things are actually quite self-explanatory, okay? And they also add in the different airway indices and things like that. Again, screening tests. So a lot of things. I'm just giving you like 3 tables already. opening already. Okay, I'm sure you guys also opening. Now, airway indices, how useful are they? Who's next? Chong Kai Lun, USM. Yeah. How useful are airway indices? So we're talking about the Malampatis and the thyromental distance and the whatever you have.
Yeah, all these indices. The indices are useful as an estimate for all these difficult airways, but they might not accurately predict a difficult intubation, or is it easy for all patients, because each patient is different. But it gives an estimate for us to prepare for difficult intubation, so we can be more prepared for either conventional normal intubation with normal laryngoscopy, or should we prepare for a big intubation, fiber optic.
Okay, so it helps you to plan your airway management techniques lah,
yes.
Right? Okay, so your answer is yes, but no. That's what I gather, isn't it?
Actually,
it sounds like a politician lah. It's
Even-
yes and no answer.
Yeah, even when we read all the studies done, actually a lot of them says that most of the time it doesn't accurately predict your difficult airway.
True.
But
So
we
we'll
still
be talking about sensitivity, the specificity, positive and negative predictive value, and things like that.
Yes.
So okay, in your routine clinical practice, what do you use? I'm sure everybody use Malampati, right?
Yes,
Okay, what else do you use?
Malampati, thyromental distance.
Okay,
Mouth opening.
Okay.
Neck mobility. How much can affect the neck?
that will probably be a part of your thyromental distance estimation, lah, right?
Yeah.
Okay.
Any loose teeth.
There's not an airway index, right?
No.
Yeah. Okay. Otherwise, there's loose teeth 1, 2, 3, class 1, class 2, class 3, very susah. Enough already, enough index already.
Yeah, usually the symptom when you do pre-med, that's what we do. When
Yeah. So basically, is the Malampati is a interdental gap, interincisor gap, and there's a thyromental distance. 3 things, is it? You do. Okay. Anything else? Nothing. So people talk about neck circumference, tak what lah. People talk about sternal-mental distance, also no use. Or people talk about jaw protrusion, no use. Or Wilson score, no use.
Useful, but sometimes they are a lot of.
So it's basically more like a research kind of thing, is it? I mean, it's not usually routinely carried out lah, right?
Yeah, clinical.
I do agree with you. I think most of the time we actually look at, the patient in general, we look at the history, we look at, the examination, we look at some but not all of these things, and we sort of make a decision. To me, sometimes it's an educated guess lah. Malampati 3, it may be a 3 to you, it may be 2 to other people, so which is a grey area, right? Unless it's the Malampati 4, then everybody gets excited, okay? So it is useful, but it's not really. I'm not going to go through all these things. You should know Malampati classification and what it is. So it's not suitable for a standalone test. If you're just basing your life on the Malampati, don't do it, okay? A lot of other factors come into play. So it cannot tell you that. Sometimes you'll be pleasantly surprised. Even a Malampati 4 is not that difficult after all, okay? Right. So same with the thyromental distance, they give you a various range where you should be worried. When it's TMD of less than 6 cm, then you actually expect difficulty. How many of you actually carry rulers or measure tapes to do it? Only when you're doing dissertation, right? When you're actually having all these projects, then you go and measure. Otherwise, it's just finger breath and things like that. Very inaccurate. How to differentiate between a 6.5 and a 6.5? Don't know lah. Maybe if I put on weight, my fingers become fatter and all that, then it's not accurate already. So sternal-mental distance is the other one. In the literature, they say it's very good, but in practice, very hardly anybody use it. Okay. Another parameter that they actually put in to confuse the issue is the sternal-mental distance displacement. When you do a sternal-mental distance, you actually do with the patient's head extended. So the thing is that they actually measure extension and neutral position, that the difference, and they say that if it's less than 5 cm, it indicates a difficult laryngoscopy. Okay, useful, not useful, nobody knows. Don't worry, I don't think it'll be asked in the exam. Okay, and incisor gap, and also protrusion, class A, class B, class C kind of thing. So there are newer indices, like I say, the SMBD. Okay, neck circumference is something that you should be aware of. The other thing would be neck circumference over a thyromental distance ratio. Okay, and then even a stop bank score. So there are a lot of newer things in the horizon. You should know about neck circumference, like I say, because they actually shown that it is a fairly good predictive test, especially for the patients who are obese and who's got OSA and things like that. Okay, I don't have the figure to tell you. Somebody knows if it's more than how much is difficult? So obviously you know about neck circumference, I don't have to teach you. The other thing that they actually talk about is neck circumference to thyromental ratio, and it's less, if it's more than 5, then it's difficult intubation. Again, this is something which is fairly new. It is this one article, it is tabular, okay, but it's something, you know, that people talk about now. Stop bank, they actually found that obviously stop bank is for your OSA and things like that, but it's just, I think it's just a matter of correlation. Patients with OSA tend to be obese, not all cases, but they tend to be obese, tend to have difficult airways. So they actually do the stop bank score to assess difficult airway, and they found that if it's more than 3, then there's a higher risk of difficult airway. I think I also can figure this out. You don't really need a scientist or a neuroscientist to find out all these things. Sort of sense of reason. Now, instead of single scores, we talk about composite score. Is it useful? Is it practical? Is it robust enough for day-to-day practice? Or is it purely as a research tool? ABCD?
B.
It's probably A. Useful, is it? So you're going to go through the Wilson score for every one of patients. Not likely, isn't it? It's something for you to remember as exam, but otherwise, I can't remember. Yeah, okay? But you should realize such things exist. I think Wilson risk sum is the most widely, most popular and most widely known one. If I ask you risk index in the exam, you probably will just peng san already because you don't know. But this is also something. Another score would be your IDS, which you should have an idea. This is not pre-op assessment. This is after you intubate the patient, and then you actually do the scoring and all that, and you try to correlate with whatever you're studying pre-op. So whether you talk about this Wilson's, how it is, and then you try to compare your IDS score and things like that, and see whether there's any correlation and things like that. So this is more for intra-op. Again, just know a little bit about it, not a whole lot about it. So I think when you use multiple indices, it is at least more useful compared to a single index. Okay, so it sort of adds up the value. But then again, the last sentence is the clinical value of this bedside screening test for predicting difficult intubation remains limited lah. We usually don't do it. Don't lose your sleep over all these things. It's just a very small part of airway assessment and management. Got all these different sensitivities, specificity, PPV, and all those things for you to mull over. It looks fairly good on paper, but actually when you do it, it's not really that great. Like test is actually specificity of 90 to 94, and mouth opening itself, I can't believe it, is 94 to 95 specific. Maybe it is lah. If you can't open mouth, obviously it's difficult lah. So it stands to reason. Okay, right. So these are some figures. Again, don't worry too much about it. Okay, am I rushing too much? Are you okay? Are you still with me? Yes. Okay, right. So let's go to the important clinical bits. Okay, so you have assessed this patient's airway. You think it's difficult, potentially difficult, not difficult, just 50-50. how would you prepare the patient for anesthesia and surgery? Usually in the exam, you'll be given not just a theoretical thing like this, you'll be given a scenario, so it's easier to talk about it. It's, let's say, an ENT patient coming in for laryngectomy, so it's easier to talk about it. But let's just discuss, for the discussion's sake, how would you actually prepare a potentially difficult airway? So everybody get equal chance. I'm calling different universities. Dina Kren, Bala Shanmugam, Dina Kren from UIA. Yeah. Yeah, the mic is video. I think it's on already.
Okay. So if I'm anticipating, if I've already anticipated a difficult airway patient, so first of all, I would want to decide on how am I going to induce, whether it's going to be inhalational induction, or it's going to be a wake fiber optic intubation, or it's going to be tracheostomy under LA. So based on my initial plan, I would prepare the OT. So if it's going to be, of course, number one is the preparation in OT. So any difficult airway, we have to prepare all the airways, airway adjuncts.
Anything you want to do in the ward first with the patient before you jump into OT? Or you want to call for anybody's assistance or any consultations or anything? I know it's a very general question, sorry about that.
So
okay, this is a very general question. Let's say if it is hip replacement, what is your anesthesia going to be?
So I would, if at all it is a case of difficult intubation, so if there is a chance, if there is a feasibility of doing it under regional anesthesia,
Okay.
I would
Okay.
choose to do
Okay.
it regionally as compared to general anesthesia.
Okay, good. I think that's the first consideration you have to make lah. Okay, right. Then? Anything you want to tell the patient?
And I will also inform the patient that if let's say my plan A is for regional AV fails, I would have to convert it to general anesthesia, and the risk of difficult intubation, difficult ventilation, losing the AV, and the risk of
Well, the patient will AR discharge already. True, I mean, those are basically the things that we need to tell, but it is difficult, isn't it, in the actual situation? Yes. But you do need to inform the patient of the potential of difficult airway and things like that lah. That's true. Yeah, anything else that you want to do pre-op? Okay, let's make it very simple. Let's make it specific. Do you have a patient, just now that patient, coming in with CA larynx and having stridor, and you actually, the surgeon plans to do a laryngectomy for the patient. How would you prepare his airway for surgery? So we are specific now, no other option but GA, okay? So the what GA bit is out, and you have a difficult airway that is in the larynx. Okay.
So definitely I would want ENT to be there.
Okay. Yeah. So you need consultation with other disciplines. Okay.
And so I would attempt to maintain whichever. Let's say if I'm doing a gas inhalation technique, I would want to maintain spontaneous ventilation
Even before that, do you want to keep the patient awake or do you want to let the patient sleep?
Awake.
You probably want to keep the patient awake, isn't it? Yeah. So you might want to talk about your awake fiber optic. You started out very well. I'm sorry I threw you off. Actually, awake fiber optic intubation is one of the options. Or if you think it's too impossible or difficult, you might want to do tracheostomy and the local, which is essentially what you've answered me. So sorry I threw you off. Okay? But of course, in the pre-op thing, you have to actually, your multidisciplinary thingy is important. You have to actually explain the risk to the patient. You actually, if you want to do awake fiber optic and all that, you might want to use anti-sialogot to try to lessen the secretions. You might want to think about your post-op management and all that. Anything that is difficult, you actually need to think about what to do post-op. Okay, so always have a idea about talking about what you want to do post-op. You might not be able to extubate this patient. You might be a long surgery, etc., etc. You might have airway edema and all that. So always good to say post-op you plan for HDU or ICU admission. Okay, so that covers all grounds. Okay, sorry, this is in OT. Sorry, wait. Oh, going back. Hey, I'm going forward, law. Say law. Sorry, show you preview already. Okay, so anticipate difficult airway. So you must think of also the technique itself. Also have to discuss with patient. If the patient say no, I don't want awake fiber optic, you can't force the fibroscope down his nose, isn't it? So you actually have to plan that. See whether he can cooperate with you. See whether there's any airway obstruction, aspiration risk, and all that. The surgery equipment personnel. Okay. So is GA necessary is the first question you have to ask, okay? And then you actually need to identify what is actually the problem. Just now we went through, isn't it? Whether it's problem with mask, ventilation, whether it's problem with laryngoscopy, intubation, etc., etc. Okay? So if you can think about all these things, try to identify and see. So this is a pre-op thing. Discuss with your colleagues. Try to actually involve them, especially senior colleagues. You might need additional assistance. Talk to ENT surgeon if you actually want to do a tracheostomy under local or you want to put in a rigid bronch or whatever it is. Have plan A and plan B and plan C. And also discuss management options with the patient, fasting, acid aspiration, anti-sialogot, post-op. So essentially you have to cover all these things in your pre-op in the ward. Okay, in OT, what you're talking about is difficult airway, trolley, assistance, suction, especially if the patient has got significant aspiration risk, positioning, ramping, pre-oxygenation, supplemental oxygenation, and monitoring. Okay, so this is basically starting to try to put in the airway for difficult case, right? So I go through, can? Can, okay? So we talk about supplemental oxygenation. Mention something like this lah. You know, you either give oxygenation either through this Thrive or something of that nature. But unless you've just read up about it the day before and you are dying for the examiner to ask you, don't stress too much on these things, because it is just again part of ways to oxygenate the patient while you're actually doing an airway maneuver. Okay, but it's good to know about all these things. These are the options that you have because it is helpful. It's not available in all cases, but it's helpful to try to maintain oxygenation in patients in a difficult airway scenario. So know something about Thrive and things like that. Okay, yeah, right. So now let's go on to some management audit kind of question. You are specialists in a new hospital that's setting up an operating theatre. You have been tasked to equip the OT with difficult airway trolley for adult patients. List the features you wish to have in such a trolley and justify equipment for difficult intubation you would recommend. Okay, so this is sort of something for you to think about, not just a clinical thingy, but something which is management. Muhammad Arif bin Sudin, are you around? Yeah, okay, Arif. So let's just skip to the question 2. What would you want to have in your difficult intubation trolley? Think about what you have in your OT. Easier to answer that way.
So
things that I would want in the trolley is different type of laryngoscope and blade. And then I would want second generation of the LMA.
So the different types of laryngoscopes, what are they?
Macintosh. McCoy.
Okay.
And then I would want the second generation of the LMA.
Okay. Tak nak LMA classic ah? No use. Just buang only. Not really useful in difficult airway. Okay, fine. Yep. So you want some SGAs there, preferably second generation, such as Procil.
And
Intubating LMA, yes.
And also I want Fuji, and also the Cook's Airway.
Okay.
And also if the department got a lot of money, we can buy some video laryngoscope.
Some, okay, fine. Berapa biji nak? Every OT.
Satu cukup.
Huh? Start with one first lah, ha? Budget ni ketat sikit. What else?
Then also
So do you want track light? Do you want Bonfils? Do you want your video laryngoscope is which one? CMAC or Glascope?
CMAC.
CMAC. Okay. Do you want Glascope also?
No need.
No need. Okay. So you stick to one. Okay.
CMAC.
Okay. CMAC je. Okay. What else?
Then also
Mention already. Cook's Airway.
the fiber optic.
Okay.
Maybe if cannot buy the expensive one, we can buy the Embuscope.
Okay. Kesian. So you want for both adult as well as pediatric, is it?
Yes.
If possible lah, If you're handling pediatric patient, you need pediatric as well. Okay, what else?
Cricotracheotomy set.
Okay, so means of surgical airway, right? But there's no point having a set if you don't have any means to deliver the oxygen.
Jet vent.
Okay, so you need that. Just mention it's a Saunders injector lah. So you actually need to have that. Otherwise, you just make a hole there and nothing is happening. Okay, right. Right, so this actually, if you get over the shock of a management question, it's a fairly easy kind of question to answer because they're all factual. It's nothing really much to trip you up. The features that you wish to have would be probably think about your intubation trolley, your difficult airway trolley. Think about what the features are. So you have a work surface up there, it's mobile, you can push it around, robust, portable, reproducible. You can stock it with a lot of things, and then it's labeled, it's easy clean, and if possible, you can attach some of these algorithm, checklists, and things like that onto the thing. So that's fairly easy to answer. I think the difficult airway equipment, this is just a list from the DAS guidelines on routine airway management. That means it's the things that you have it on your trolley all the time. Isn't it? You have all these face masks, airways, LMAs, ETTs, etc., etc. Okay. For a difficult airway, an anticipated difficult airway, then you have got the other more involved things. And I think, what's your name again? Arif has mentioned most of it already. So it's all there lah, Okay. So I won't go through all these things. You can read it at your leisure. So, okay, this one already answered just now. So just go through with it again. So I think these are the sort of steps that you should have it in your mind. Okay. If you can avoid GA, whether you want to do it awake or asleep, whether you want to do it non-invasive or invasive. Invasive means straight away you just ask the surgeon to trachea under local, problem solve, induce the patient after that, hook it onto the breathing circuit, everybody's happy, you can go to sleep. Okay? And whether you actually need to intubate the patient in the first place, or whether you can actually go away with doing SGA only, whether you want to use, so just to mention in the new one, these are the changes now, okay? So they put more emphasis on the use of SGAs, the LMAs, intubating LMA and laryngeal tube. They do mention laryngeal tube in the protocol, and also they talk about the difficulties, they define what is difficult SGA. Last time, previously, it is just mask ventilation, laryngoscopy, intubation. Now they add in the additional feature about SGA ventilation. So they give you the different definitions and also difficult SGA placement, like we've gone through it just now in the first place. They added in video laryngoscopy, either as an initial approach or as a rescue technique for intubation. They don't mention rigid bronchoscopy anymore in the as an emergency non-invasive airway technique somehow. They also talk about jet band and retrograde intubation. They also have got radiolaryngoscopy added. Retrograde is actually removed from the protocol itself, but in the text they mention somewhere about retrograde intubation. Anybody has seen or done retrograde intubation? No, lost art again. You know, like me also, I haven't actually done anything. So if I haven't done, I don't expect you all to have done it. I belong to the old school. So these are, I just put the arrows in to show you the new things that is happening in the difficult airway algorithm in ASA. Won't have time to go through all these things. Let's just talk about unanticipated airway, because this is important for exam. Okay, so your junior colleague cannot intubate this patient planned for elective hemicolectomy. Okay, what would you do to help? Patient already, you've given the induction agent, you paralyzed the patient, just that you did the laryngoscopy, you cannot see anything. So what would you do? Back to you, KM. Chan Wing Kin.
In this case, first I'd like to assess the patient, look at the monitor, see whether the saturations are okay, able to maintain or not, the blood pressure, and also the vital signs. And then at the same time, I'd like to call for help.
You are the help. You are the sifu. This is a junior colleague, so you are the help.
Okay, so once I ascertain patient's condition, so I like to see whether any immediate management needed or not. So as for airway, I like to increase the FiO2 increase the flow of oxygen to 100%, and subsequently see whether any secretion or not. If there is, clear off all the secretion first, then and also.
Sorry again, what any?
Secretions.
Secretions. Okay.
Yeah, then I'll manage ABC. Then subsequently try to must ventilate just to make sure the end tidal is O2 is more than 90%. So once, if let's say,
what is more than 90%? End tidal
oxygen.
O2. Okay.
So if let's say unable to, then I'll proceed with DAS difficult airway guideline. The first one, which is try and attempt another step of laryngoscopy, see whether what is the view or not. If let's say still cannot see, I might actually proceed with SGA, either intubating LMA or ProSeal. Then after that, I would like to assess and see whether is it any difficulty in insertion or not. If let's say there is none, then I will just continue and stabilize the patient. Then if let's say
so are you happy with the SGA for a hemicolectomy?
No.
Huh? So what would you do?
If let's say there's already a SGA for intubating LMA, I like to arrange for fiber optic and then do a railroad guided intubation.
Then this fiber optic is through the SGA?
Yes.
Okay.
Then
have you done that?
Yeah, but in mannequins.
In mannequin, yeah. Not so easy in the real life now. Yeah, okay. But that's an option now.
Then after that, if let's say that SGA method also cannot, then I would like to proceed with mask ventilation, backward mask, with not more than 20 centimeter water. If let's say there is still unable to maintain adequate oxygenation, then I like to discuss with my surgical colleague, maybe need to wake the patient up and then postpone the operation because it's an elective hemicolectomy.
But you're telling me that time is already, but you are unable to maintain oxygenation, is it?
if let's say unable to maintain oxygenation, then I like to consider either waking the patient up with a reversal, like sugar Medex, or if not, I proceed with front of neck access.
Okay, right. So you're actually basing your answer mainly on the DAS guidelines and all that, which I assume you've actually read and you're quite familiar with it, right? Okay, Ken? Okay. So again, essentially, I'm going through the DAS guidelines with you, okay? So I think, again, in the interest of time, I cannot go through everything. I just pick out the essential things that you have. So when you actually talk about your plan A, in this patient, that's what you actually need to do. But let's say if you have failed plan A and all that, the things that you actually need to do, you actually told me just about doing another laryngoscopy. But I think patient's positioning is important. So in the exam, you still have to mention that whether the patient is in the optimal intubating position. So if the patient is not, then adjust the position. Either you make sure that he is in the sniffing position, intubating position, or if the patient is obese, then you might have to ramp patient further to actually make sure the position is optimal. And then whether you want to actually change the intubating device or the blade, or whether you want to use adjuncts, or make sure that the patient is adequately paralyzed, and also your assistant, the bird maneuver and all that, and also personnel yourself is there. So when I answer that question, I don't really go through, it cannot be theoretical, it has to be fairly practical. And I like what you said. First of all, you look at oxygenation, you see the SpO2, make sure that patient is not desaturating, for example. Then you know that you actually still have got a little bit of time to play with. Okay, you can still do all these things and make sure that you have a good proper attempt, or maybe in the meantime call for a video laryngoscope while you're actually assessing a patient and doing all these things. So that's important. Okay, and then you will, like you did, you go through the different stages lah. If you actually can intubate, that's the end of the story. Patient can proceed, surgery can proceed, and they can go on ahead with the hemicolectomy. If it is not, then you're actually talking about SGA, and I think you have to mention what you want to use. Whether you, I think 99% of us will be using a Procel, isn't it, rather than a classic. Or do you all use intubating LMA? The fast track? Which is very sad, because I feel that is actually a very good, especially at the end of the day, you want to intubate the patient. So I think we have actually lost the art again. When it first came on, we actually were using it fairly routinely, so we were pretty good. And then when Procel LMA came to us, and then we sort of lost the art. But actually, if you want to have, at the end of the day, you want to intubate the patient, that probably should be the thing to aim for. Because after all, that's designed for you to intubate the trachea, isn't it? Rather than putting in a Procel, if it's okay, then you think about how to convert it, want to railroad the thing and this and that. Very susah for that, and a lot of maneuvers required. And in the meantime, you might actually lose the airway when you try to do too much of manipulation in and out and things like that. So consider the use of fast track as well. But basically, again, it is three attempts only, because they found that anything more than 3, your success rate goes down, and then you get a lot of problems with edema and secretions and blood and things like that, trauma and things like that. Okay, so so then if you actually can have what am I doing? Okay, if you actually can have this one, that's when you stop and take stock. Okay, that's not when the patient start to desaturate, you think about whether to wake the patient up. This is the stage where you actually want to think what to do. Once you have the LMA in place and the patient is okay, still not awake, and you can ventilate the patient, this is when you stop and think. Okay, whether you want to postpone an elective surgery, whether you want to change over to intubation, whether you want to ask the surgeon to proceed but do a very short surgery if it is life-threatening and things like that. So this is the options where you have to do. Once you go past that, you cannot actually go stun already. This is the place when you have plan C, there's actually, when you talk about failed supraglottic airway, and you take out the thing, and you try to mask ventilate the patient again, try to oxygenate, and then if it's possible, then you wake the patient up here, if it's possible to oxygenate, otherwise you go to front of neck access already, okay? So, plan C also says that if face mask ventilation is impossible to paralyzed patient, okay? A lot of us have got a lot of reservations about this. When it first came out, is everybody say, what to do? Because the classic teaching is if you actually give RSI, you give sucks and all that, you just, wait for the sucks to wear off and you wake the patient up and that's it. This one is say, on the contrary. I try to look at the literature and there's very little to say anything about it except Das himself, Difficult Airway Society documents itself. I try to look through, but there doesn't seem very much discussion. Everybody seems to like just accept it. So, but they do have the rationale and all that. Like, you know that they say that if the patient is struggling, is breath holding, is having all these things, it's more difficult for you to intubate and things like that, or for mask ventilation itself. So that's why they say things like this. And if you actually use rocuronium, you can use sugar Madex and things like that. So to them, that's how it should go, but they make it very strongly worded that further attempts should not proceed without full muscular block. Okay? So when you answer in the exam, you can say this, and you can say that it's actually as recommended by Difficult Airway Society guidelines. Okay? And because this is the obstetric one, obstetric also they say something about that. I just circle there for you. Ensure neuromuscular block. So both ways, different situations, they say that you should actually paralyze the patient. Okay? Then you come to the front of neck access already and things like that. Okay? Right. So just different things. That's why I say DAS guidelines is very nice, very logical, and very easy for you to reason out, for you to remember. So it's good to reproduce this in the exam lah. ASA is a bit mafan, okay? Right. So I won't go through all the CICB's things, okay? Every equipment I'm going to. Can I skip I only have 15 minutes with you, and I'm sure you guys are hypo already. All haven't had breakfast, isn't it? Okay, so these are for your reading before bed so that you can go to sleep easier. Okay? Okay, video laryngoscope I need to go through with you. So explain why tracheal intubation can be better achieved by using video laryngoscope as compared to conventional Macintosh. I won't ask UKM because you've already answered this last time. Siapa? Daniel Chow Ren Kiat. Daniel? Okay. Yeah, Daniel. Okay. Why do you want to use a video laryngoscope in difficult airway? But you not necessarily use a D blade all the time, isn't it? You can use a normal blade as well. But even normal blade is better than your conventional Macintosh, right? So why?
And it allows visualization not only to me but also to my assistant.
Okay. But that doesn't explain why is your intubation easier. Okay, to the assistant in the sense that he can actually try to maneuver your burp to make sure that it is well visualized. Okay, fine. Right.
And it also limits the cervical movement during intubation.
Why?
Because if we are using the conventional laryngoscope, we have to extend the patient's neck
Okay.
to align the oral, pharyngeal, and laryngeal axis.
Okay. Yeah, what is the design in the video laryngoscope to enable you to visualize better with the patient in a neutral position? That's the gist of the question. So you have to talk about the design features of the video laryngoscope. Okay, I hear some whispers about angle of the light. So what about the angle of the light? Yep. So it's much wider angle, isn't it? Your 60-degree angle. It's just like a fish eye view like that. You actually can see better. So your visualization is much better compared to your conventional Macintosh laryngoscope. And if you want to use D-plate, then of course it sort of makes it even easier lah. Okay. So right. Please be aware that we are only talking about a small portion of video laryngoscopy. It's not everything is CMAC sahaja or GlideScope if you are used to it. If you're actually looking at video laryngoscope, basically the idea, the definition of video laryngoscope is a laryngoscopy using the video technique, isn't it? So the other things are also equally, is also classified under video laryngoscope. So you have the, C-track, you've got the airway scopes or air track, Bonfils itself. Before you actually come to the I don't even know what VMAC is, but CMAC lah, and also the GlideScope. So when you describe, you can talk about laryngoscope in general, but when you give examples, you have to say, for example, in CMAC, it's like this, like this, like this, okay? So just have a full picture, big picture rather than just focus on CMAC itself. So, and you need to know the components of video laryngoscope. Basically, you will have to have the blades, obviously. Reusable, interchangeable. You can use the various sizes or various types of blades available. Okay, you also need a camera. Okay, you need sort of a monitor for you to see what is being shown at the laryngoscope level. And also, you need to have a power source. Okay, these are the components of a video laryngoscope. Okay, which you should know. So when you're actually talking about conventional laryngoscopy, you actually need to align the axis, like we've said before. Okay, so that's very exacting lah. You have to do that. Okay, whereas video laryngoscope, you can actually do it even in the neutral position. Your camera is actually acting as an eye for the operator and is at the pharynx of the patient, so you actually can see a bit better. So that's why we talk about the 60-degree angle for you. Okay, either using the Macintosh blade or the D blade and all that. So you actually have got a better view as compared to 15 degrees. So this diagram is very useful for you to remember, and you have to sort of mention the angle of view, as compared to the conventional thing. So the other advantages, other than improved laryngeal view, is that you don't actually apply so much force to your patient's the front of neck, the teeth and all those things, and also higher rate, of course, intubation success, good for teaching and training, and then you can visualize, so improve assistance and clinical governance and all that lah. So the question is, should it be used as a routine? So every OT should be stocked with video laryngoscope, and everybody can throw away Macintosh. Cannot, isn't it? Okay. So a lot of times, even my trainees, when they say it's difficult airway, they call for CMAC. I say, wait, you use a routine, a conventional first. See whether you can do it or not. Otherwise, the skills of your laryngoscopy is going down to the dogs already. Similarly, every difficulty, if you think difficulty, okay, you don't want to intubate, you're going to use Procil, your intubation skills is also going to go to the dog. So I don't agree that it should be used as a routine lah. As a rescue, yes. As an important component of a difficult airway equipment, yes. Okay, 20 minutes, 10 minutes. Okay. Okay, these are the various other things. I'm going to skip right through because LMA, I'm sure you know. So I just put a cross here. CombiTube is, I told you, it's not an ASA algorithm anymore. So just know a little bit about it. Don't have to know a whole lot. neither is a laryngeal tube also. It's something which is useful actually, especially if your mouth opening is very small. If you can't slip procedure through, we've actually done a case report on this one. Somebody with burns contracture, half the mouth is covered, and we actually use laryngeal tube to actually maintain the airway, let the plastic surgeon slit the thing wide open, then we change over to intubation. So it's actually something useful. Okay, and LTS2 is similar to ProSeal because they've got a suction port as well. Okay, and iGel and ProSeal, skip. Sorry, I have to skip. Okay, special situations. These are the ones that you're more likely to be quizzed in the exams because they are sort of the ones that are known to be difficult. So like patient, obstetric, morbid obesity, diabetes, rheumatoid arthritis, scleroderma, the syndromic features and things like that. ENT cases, laryngeal surgery, tonsils, capsule, patients with OSA, surgery, thyroid or other neck masses with or without retrosternal extension, mediastinal masses. I think you have a lecture on that, isn't it? Mediastinal masses is one of the favorite exam questions. Okay, always be prepared for that, either in the SAQs or in the Viva. Maxillofacial trauma, Ludwig's angina and dental abscess is again fairly sort of favorite exam questions. Acromegalic coming in for pituitary surgery, hydrocephalus patients, trauma, either cervical injury, airway burns, okay? And upper airway obstruction, either by a tumor or foreign body inhalation or acute epiglottitis and all that. So these are the sort of very common exam scenarios that you all have to be prepared for. I suggest that you think about each and individual one. You think about possible questions that might come out, and you think about how you're going to tackle these questions. Because I find you cannot have a recipe, just standard recipe for every airway difficulty, because sometimes it can be because of airway obstruction, sometimes it can be because of difficult laryngoscopy, for example. So it's a bit different. Let's say you're comparing somebody with a fracture, a zygomatic fracture, and who is got trismus because of pain. That one, if they don't have any difficult intubation feature, is usually fairly easily settled by just anesthetizing the patient. Under anesthesia, the mouth opening is better than get intubate the usual way, as compared to somebody with Ludwig's angina. Then you probably have to, in the exam especially, you have to talk about awake fiber optic intubation, because you know all these things are not going to be settled by anesthesia, because they are going to have swelling and things like that. No doubt there's pain, but there's also soft tissue swelling as compared to, you know, a zygomatic fracture, for example. Okay, so different situations have got sort of slightly different approach to it, slightly different, number one, airway management technique. Of course, the plan B and point C might be the same, but your first approach might be a bit different. So I suggest that you go back and you look through all these things and you try to figure out how you're going to answer these kind of questions. Okay, right. Okay, let's do this one. There's somebody had a fight, and you got this fella transferred to you, 24-year-old man with mandibular fracture. Blah blah blah, he's got all of history. The question is, what features on examination of this patient would suggest a difficult airway? A bit out of the ordinary kind of question, isn't it? USM, where are you? Muhammad Ramzi? Where are you, Ramzi? Okay. So, this fellow with the mandibular fracture, so what would suggest to you that it may be difficult? Are all mandibular fractures difficult?
No.
Okay.
If this patient has a bilateral mandibular fracture, most probably it will be a difficult airway.
Okay.
And then, because this patient is actually came from brought out of prison, he might have other injury as well, such as cervical injury, which
Okay.
can be features of a difficult intubation.
Okay.
And then can also assess the other traumas such as airway swelling.
Okay.
He also might be uncooperative in this condition.
Okay.
So it will be difficult for us to induce this patient.
Okay. Very good. Yeah.
And then if this patient is being, I assume that this is an emergency surgery, he might not be well prepared in terms of fasting time.
Okay. Right. That can limit your options for difficult airway, isn't it? For airway management. Yeah. Okay. Good. Yeah.
Anything else?
Okay. I agree with you. I just touch on the airway aspect, the mandibular fracture aspect. If you actually have just isolated fracture, usually they don't move very much, so that's not a problem. Okay. And unlike those Lefort fractures and things like that, but if you actually have got bimandibular fractures, then you can have flail segment. Then they can actually, especially the one that has got the posterior inferior displacement, because they can actually impact upon the airway and cause acute airway obstruction. So these are the ones that are difficult, that are going to be require emergency intervention. And of course, once you kena tumbuk already, you have to worry about dentition itself, whether there's any loose teeth, any avulsion, whether there's any bleeding inside the oral cavity. That can make your intubation that bit more difficult. And also, usually when you put the patient under GA and all that, there's not much of an intubation problem if you can actually displace the jaw anteriorly and things like that. But yes, this is only on the mandibular fracture. What you've actually put in regarding the patient's whether the patient can cooperate, whether the patient is intoxicated, for example, or high on the intravenous drugs and things like that, whether the patient is adequately fasted, those are the things that you actually need to consider when you actually handle the airway and things like that. I'm afraid I don't have time to go through everything already. I have to skip all these things for you to, just take back for you to read. They also actually have got an algorithm for the, too many algorithm, for trauma itself, they also have got algorithm for you. Okay, I won't even have time to do obstetrics, so I'm going to skip that. I want to do the last bit about extubation. Okay, this is about airway anesthesia. Okay, extubation, geez, always. What are the considerations while planning extubation of problematic airway? Okay, last 3 minutes. Let's have Mani Mahfuza from UIA. Yeah, okay, Mani. So you've got this patient that is is unexpectedly difficult to intubate. And then what are the considerations you want to have? Okay, I'm going to skip this one. Go to the last question, which is actually the exam question. This is what you had last time. Anybody read about this examiner's report? You read? Okay, haven't read, just answer like a new question. So 50-year-old woman, right mastoid, difficult unexpectedly, easy to backmask ventilate, after multiple attempts, can intubate, and then you proceed. So what are your management strategies for extubating this patient? This is what I was asking you anyway. Okay, so just answer part A. What are the strategies that you have?
So because already multiple attempts, so I will consider that drugs that can reduce the edematous airway first.
Okay, so you put on some steroids.
And then make sure the ventilation parameters is good on the ventilator. She can breathe spontaneously afterwards, and then I try to do the leak test so that if it's positive, then possibly the edema have subside, and then ensure that
How long does your mastoid take? Your surgeon in USM. How long do they take?
Kalau biasa kali 2 lah.
Did I hear 5-6 hours?
Yeah.
Dahsyat, huh?
Yeah.
4-5 hours. 4 hours.
Masa itu ni.
5-6 hours.
Kalau habis hari
Okay.
tu,
Just wondering whether the airway edema can subside by then. Probably not. Okay. Anyway, your approach to the question, yeah. The question actually asks you discuss your management strategies for extubating patient. It's not asking you how would you extubate this patient. Yeah. So when you have to discuss, you have to actually give the options. Whether it should be this, whether it should be that, which one is the pros and cons. Discuss. Yeah. Okay.
Meaning, either I'll directly extubate in OT, I will consider how long as the operation takes and how much the manipulation has been done. If not possible to be extubate directly after operation, I will consider manage the patient in ICU or HDU for later extubation in better monitored condition. So if later, then I will consider giving continue all the steroids, doing the test later, make sure patient is properly wake up. Okay. Command, then I will consider the extubation.
Okay. Okay. Yeah. Anything else? So there's early versus late extubation. Okay. Anything else? Awake versus asleep. Would you actually consider waking the patient up, make sure that she's fully awake, which I think you will, isn't it? Rather than pull out the tube when the patient is half asleep. Kind of silly to do that, right? For a difficult airway situation. Okay, what else you would include in your management strategies? Just now, part of it you answered, all these the extubation criteria have to be fulfilled, right? Your adequate tidal volume, able to be awake, obey commands, etc., etc. So there's a whole lot of extubation criteria you need to fulfill and adequately reverse from the neuromuscular blockade and things like that. So that's also part of the answer. What else?
Okay, maybe consider putting like Cook's airway, the airway exchanger.
Okay, Cook's airway exchanger. Yeah, that's a good strategy. Okay. What does that do?
In case of immediate intubation needed again, so we can revert from the airway exchanger.
So can you just put in a bougie? Your usual gum elastic bougie that you use for intubation?
Bougie doesn't have the port to ventilate because it doesn't have the connection, ETT connector on the top.
Okay, so you need the RepiFit connector for you to give oxygen through the port, isn't it? And it's a hollow thing. It's not the solid, solid rod like a bougie. Okay. Anything else? So during your discussion and all that, I think you actually need to talk about events during the intubation attempt itself. Exactly how difficult it is, what was the problem, and how to solve it. So you know whether it is a comic lane 4 they're dealing with, or whether you cannot position the patient properly, that's why it's difficult, or whether it's because of inexperienced anesthetists in the first place. So you actually need to know the circumstance around there. Okay. The other thing would be the events of the surgery. In this case, it's nothing very much to talk about lah. It's a mastoid, so it's a mastoid lah. Surgeon will take how long time, but hemodynamically, you don't expect much problems. If it is different scenario, let's say is nephrectomy and all that, you might have problems with blood loss and things like that. Patient might be hypotensive, patient might be hypothermic and all that. So those are the things that you really don't want to wake up the patient and extubate, right? Okay, so talk about the intubation attempt, talk about the events during the surgery, and then talk about extubation criteria, whether the patient fulfills, discuss about whether the patient should be awake or should be asleep, and then talk about how you're going, whether the patient can be extubated in the OT or brought somewhere else to extubate later when the situations are more controlled. And then you talk about before you extubate, what are the things that you need to do, like you say, a leak test and things like that. And then it's a good practice to put in a Cook's airway exchanger so that you can railroad any EGT down if the patient runs into problem. Talk about monitoring. So these are the things that you actually should discuss in your question, in your answer. Yeah. Okay. I think is exactly what I've told you. The second part, this patient, sorry, 5 minutes late. This patient developed laryngospasm after extubation. Outline your subsequent management. Lee Jing Xian from UPM. Last question for the session. Yeah. Okay.
So FiO, put on FiO2 high flow oxygen, then subsequently followed by want to remove anything that can cause the laryngospasm, for example secretions, or is there any airway adjunct that is still in the mouth? I will just remove it. Then back ventilations, put a bit of CPAP PIP. And subsequently want to deepen the anesthesia, like providing IV propofol boluses, and because inhalation anesthesia is unlikely to deliver to the patient in case of total laryngospasm. And subsequently, if let's say see whether can maintain the ventilation. If couldn't, then I would consider to use a bit of muscle relaxant. Just to balance.
So you've got propofol on board and you've got muscle relaxant. What are you going to use?
Can consider use saxamitonium, like 1.5 to 1 milligram per kilo. Then
this patient, I assume that rocuronium or some non-depolarizing muscle relaxant has been used intraoperatively. So is it so advisable to follow up with a depol? If it's a small dose, it doesn't matter, is it? I would be a bit hesitant. I'll probably use propofol and things like that. But to answer the question, you actually need to put yourself in that situation. So this patient has been extubated. You really don't know where the patient has been extubated, whether in the OT or whether the patient has gone to ICU or PACU or whatever, extubation. So it can be a bit different in your approach. But yes, you actually need to start by saying about attending the patient immediately and also looking at the patient's other parameters, especially the saturation as well as the hemodynamic parameters, and then continue where you started just now. Okay, make sure that the airway is patent. Make sure that patient is any secretions of blood or vomiters and all that has been cleared by suction and all that. You might want to do a jaw thrust and all that if the patient is not not conscious or whatever it is. And then you talk about trying to relieve the laryngospasm due to various causes. So things like that. We're going to talk about the crisis management a bit later, so maybe we can actually discuss that further in the other section. Is that okay? But the gist of this thing is this patient has had a difficult airway. So somehow, whatever it is, sooner or later, you can talk about all these various conservative management, but at the end of the day, you actually have to address this issue. You might have to re-intubate this patient. So how are you going to do it? So you have to actually talk about maybe the first try earlier on was using a laryngoscope, a Macintosh. So this one you call for, your difficult airway trolley. You maybe start out with a video laryngoscope. Maybe you want to use a smaller size tube. Make sure that you've got gum elastic bougie ready and things like that. So those are the things that you actually need to mention for this particular question to make it complete. Okay? Can? I think the answers are all here. So we actually talk about all these things, your triggering factors, your CPAP, deepen the sedation, you might want to use the IV succinylcholine. This is in the examiner's report and all that, but I do personally question this one lah, and then intubation if condition worsens. So that's what we have. And I think it's a very, very rushed overview about airway management. I hope you all have learned some. Audit type crisis management questions won't come out. It has come out in the exam. So I just give you an example. In May 2017, they asked about critical incident and anesthesia. So everybody got a shock. What is this critical incident and all that? So what is a critical incident? What constitutes an adverse event? Illustrate with examples. Elaborate on the general processes that need to be followed after the critical incidents. So do you sort of get shocked when you get this kind of questions? Yeah, usually we get scenario type questions. I mean, they'll give you one thing about, let's say the patient has got SpO2 dropped down to 88%, what would you do? Then we blah, everything we do it. But once it comes to this kind of audit type, management type questions, people start scratching your heads and all that. But let me assure you, this is not too bad. You can, and after you get over the initial shock, you actually can write something about it. Like giving examples are very easy and things like that. And also the general processes, you just think about what you do. Hopefully you don't have to come across these kind of situations very often lah. But let's say if you do have a patient that suffers, what are the things that you actually do, you know, in the OT itself, in the after events? What are you going to do? How are you going to write it up and things like that? So I think this kind of questions is doable. Okay, just keep cool and think about what you do in your usual practice and all that. This is another example in the FENSCA, October 2018. All they ask is to discuss the non-technical skills required for management of intraoperative crisis. Even more vague, isn't it? So they don't want anything to do with how you manage this patient. They are just asking you to talk about the non-technical skills. Just a one sentence question, and you left scratching your head. What do they want? Okay, we'll discuss that a bit later. I'll just go through all these things about critical incidents. Okay, so what do you understand by the term critical incident? Ling? I hope there's no link in other universities. We meant you lah, Ling. What's your surname? Ling Heng Wei.
Critical incident means any incidents which can lead to any undesirable effect towards the patients. So, for example, probably, this connection was secured. There is aspirations.
So give me examples.
Inadequate fastings. Probably wrong drug administrations. So all these can consider critical incidents.
Okay, when you actually ask to, so what you understand, or ask to define and all that, you don't necessarily have to give examples lah. But of course, in the viva situation, when the examiner is staring at you and wanting you to talk some more, then you start off with all these examples and things like that. Not necessarily wrong, but most of the time we just want, your definition itself. Okay, so basically, critical incident is, like you said, untoward event that causes or has the potential to cause life-threatening injury or permanent disability. Okay, so something that's serious, it can either cause it or it has the potential to cause. That means it doesn't necessarily have to happen. So like I say, if a disconnection, if you leave it long enough, you can cause medial morbidity, but it doesn't have to if you actually rectify it straight away. If you compare it with pain, definition of pain, which I'm sure you remember from your primary days, okay, it also says something similar, an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Okay, so they don't have to happen, but they have the potential to happen. So that's what critical incidents is all about. So I actually help you to answer this first question already. What is a critical incident? So okay, pass 2 marks, you get 2 marks. Okay, right. So the incident may or may not be preventable. Okay, some are obviously due to mismanagement, due to negligence, it is preventable. Some are not preventable. Let's say, you've got patient with no history of allergies or anything, suddenly he develops an anaphylaxis. That's not preventable in that sense. Obviously, you can give a test dose and you see and whatever, but still, a test, if your patient is prone to anaphylaxis, a test dose itself can also give you a full-blown anaphylaxis anyway. Okay, so it may or may not be preventable. Is that clear? Is it okay? Okay, the second question is, critical incident reporting is useful or waste of time? For exam, say useful lah. But you have to fill out all the incident report forms and all that, you say it's a waste of time lah. Okay? So just go through with you. So these are the uses. I'm just going through this because in case you get asked in the exam, yeah? So it is educational. You need all this reporting to document rare conditions like MH or atypical pseudoconiosis, which we don't really come across much. Okay, identify underlying causes, develop preventive strategies. Like if a patient, in the past you've got a Mendelssohn syndrome, your aspiration, so they have got fasting guidelines, acid aspiration prophylaxis and all that. So it's through incident reporting that they actually develop all these guidelines, and then monitor and manage field complications, failed airway, dural puncture, LA toxicity. So they developed algorithms and practice guidelines through that. Decision-making analysis in terms of staff. Let's say that they find that the GA assistant is lacking in number or in quality, in the experience and all that, they train more staff. Or if they find that you've got you don't have enough capnograph to go around the OT, they make sure they have budget for that the next time around. Service, let's say if they find that 24-hour call service is not good because people get very tired, they might want to implement shift duties and things like that. So decision-making analysis, that's good. So these are the uses and the advantages of critical incident reporting. How can critical incidents in anesthesia be reduced? Josephine Chan. Yeah, how do you reduce critical incidents? Again, it's a very wide general question.
Depends on the incidents whether it's preventable or non-preventable. If it's preventable, we can assess identify patient at risk, and then also pre-operatively we can take some measures before the operation and during the operation and after the operation. And if it's unpreventable, it will be an emergency situation or life-threatening. We need to call for help and approach with ABC approach.
Well done, well done. I know it's a sort of, you've been thrown this kind of questions and you don't think about it. All you think about is clinical scenarios and all that. It's kind of hard to answer, isn't it? True. I would be struggling like you. Yeah, okay. So you want to start off by saying whether it's preventable or non-preventable, and then you go on to talk about various things and all that. I think if you actually have in the back of your mind what causes critical incidents, then it's easier for you to answer. And so you know the causes. I think it's better that you know your causes to discuss how to prevent them. It's just like AIM study in the Australia in the early 1990s. They actually talk about the causes first before they actually talk about ways to prevent it. I think the commonest factor is human factor, isn't it? So when you're distracted, when you're tired, when you don't have enough training supervision, when you're having the pressure to proceed because surgeon is breathing down your necks and things like that, when you actually have got very poor assistance from your GA staff, when you don't communicate with the surgeon, when you don't involve your senior colleagues to be helping you with the difficult cases and all that, those are the things that constitute critical incidents. Okay, so just have these things at the back of your mind as a background for you to answer that prevention question. So you have all these things on board. The other causes will be equipment. If you actually don't have the appropriate equipment, when you don't check, when it's not being checked or serviced routinely, when it's used inappropriately, let's say you've got somebody with a fat arm and you're using a small cuff, BP cuff and things like that, when it's faulty, when you are not sure, not familiar, for example, in the out of OT situations and things like that, those are recipes for disaster lah. And then drug courses, whether you're using the correct drug, whether you're using the correct dose, whether you're using correct dilution, or whether the drug is expired. Again, drug causes sometimes can be attributed to human error as well. Distraction, inattention, giving the wrong drugs and giving the wrong dilutions and things like that. It can be human factor, it can be drug factor. Yeah, so you have that in mind, then it's probably easier for you to answer the question, okay? So easiest actually is to talk about equipment, how you're going to, maintain the equipment, how to check the equipment. Personnel will be things like trying to have adequate supervision, adequate proper working hours, and then having a discussion with the surgeon. All these things that I've already given you in the first two slides, you can actually incorporate into your answers. Okay, awareness mean basically is under training and education as well. Recognize the risk factors involved in the cases that you're actually doing, have proper pre-op optimization, preparation, and all your fasting measures, your whatever medical or surgical preparation and things like that, monitoring your anesthetic practices, post-op care as well, and also CMEs lah. So when you talk about CMEs, will be all these things. Critical incidents reporting, we already talked about. CME, hopefully your M&Ms are not going to be witch hunting, and hopefully it can be discussed in a very educational and non-critical atmosphere. Case reports and journals are good sources for you to go to help yourself to update yourself. Simulator training, unfortunately, is for UKM is talk rather than do. Okay, clinical practice guidelines, protocols, and also specific algorithms. Okay, we already talked at length about DAS airway algorithm, so things like that. So they're useful for you as guides. I put a question: how useful are these clinical CPGs and protocols? They're only useful if you read it, if you follow it. Otherwise, you've got committees after committees putting out all these protocols which nobody reads. Then it's a waste of time. Yeah. So all these things are only as good as the reader and the practitioner. If you don't make use of it, then you'll still be going along your merry way lah, without much thing. I won't touch about cover ABCD. This is way back, in the 90s, when I was studying for my FANSCA, I had to memorize all these silly things, which I find in actual practice, you can go through all this, the cover business, and know that it's supposed to be 60%, you can pick up 60% incidents. ABCD, cover ABCD itself will pick up 95%. Very hard to remember all these things in actual fact. I mean, it is a way, it is an attempt to make it very complete. If you're going for FANSCA exam, you have to know this, but elsewhere, I don't think they actually bother very much. A swift check will be to cover the rest of it. You cannot remember a swift check because it is a whole lot of nitty-gritty details and all that. Cover ABCD, at least you can sort of use the mnemonic and try to remember things. So this is one of the things, one of the examples of the algorithms that you have. So now, let's say you're involved in an anesthesia crisis. How are you going, what steps would you take to try to manage this crisis? Again, this is not clinical scenario, this is talking in very general terms. What are the steps required in anesthesia crisis management? USM? Kuzaima? Siapa Kuzaima? Okay. How would you start?
First of all, I would like to declare crisis.
Okay.
Raise your hands. Then supportive managements like EBC, then followed by specific management of the case.
Okay.
And then report.
What else? So you you declare crisis, you call for help. So you've got is announced over the PA system, code blue in OT2, and everybody runs. So when you got all these people running to you, what do you do?
Delegate the task.
Okay, delegate. You can delegate your responsibilities. You set lines. You dilute drugs. You run for blood and things like that. So delegation is important. What else? Surgeon asking you, can I proceed? I carry on.
So you should consider to stop surgery
Okay.
at the point of time, and then
Cannot stop when the arterial bleed is spurting, isn't it?
yeah.
Yeah, so they have to do whatever they can to actually arrest the bleeding, or and sort of if you need them to CPR for you, they have to stop and do whatever lah. Okay, so make them useful. Okay, even though they're mostly useless. No surgeon here, no spine here. Okay, what else?
Like I mentioned earlier on, we depends on situation. We manage based on the ABC approach.
Okay.
I mean,
Okay.
supportive management in order to maintain the hemodynamic and respiratory components. I mean to stabilize the hemodynamic and respiratory components, and then after that maybe need to consider a specific targeted approach towards what is the crisis.
So at the back of your mind, you should have some differential diagnosis or some likely diagnosis, isn't it? Otherwise, you'll be just doing the ABC without knowing what's going on. Yeah, okay, right? So you have start your therapy, whatever it is, hopefully specific to what you think is the problem with the patient, and then you need to reassess the patient to see whether the patient has responded to your treatment or has gone worse or whatever. So in that case, you might be barking up the wrong tree, and you have to rethink about your diagnosis and things like that. Okay, what else?
So you have to consider the post stabilizations plan. What you might or you to consider after the patient is stabilized, whether to proceed with surgery or to postpone and send that patient to ICU.
Okay, yeah. So that comes to the already like the subsequent management already lah. Whether you want to actually what you plan to do with the patient, whether to continue, whether to close, whether to postpone, and subsequent care about the patient. Yeah. What other things that you need to do?
Documentation.
You get a junior most to catat. Documentation is very important. Obviously, when you're resuscitating the patient actively and all that, there's nobody to document everything, but you actually need to have somebody to write down, hopefully fairly time specific lah, that you can actually document what actually happened to the patient, what was being done, and the drugs and the doses, etc. It's useful, of course, if you actually have got the automated printout for your all your vital signs and things like that. Then you can actually know the time frame. Otherwise, everything would be retrospectively. Okay, and if there's a major morbidity that happens, what are you going to do? What is your response? This is also in the answer to this question. Yeah?
Need to explain to the family members regarding what is happening. I think we need a multidiscipline, involve multidiscipline, which is include a surgeon and anesthetic regarding what is happening to the patient.
Yep. Yep. Okay, and if the unthinkable happens, if the patient dies and all that, then you need a period of debriefing and what they call it, discussion and things like that. Okay, so again, it is a sort of a difficult kind of thing for you to talk about because it's very general. You're not having a specific case, but this is the thought process that you should have. So your initial response, okay, don't hide under the sand and think that it's not happening to you, it can't be happening, extra, etc. So initial response, take commands as the team leader. That means you delegate responsibilities and all those things. Declare crisis if you haven't done so already. Work on your first diagnosis, your provisional diagnosis. Think of the differential diagnosis and all that. Reassess, re-evaluate the situation as you go along, and then see whether there's any further action to be taken. For all you know, you might have missed it, so you might want to actually go back to it and do something, or further action like you need more blood, you need more blood products and things like that. So you actually have to ask people to run for those things. Retrospective documentation is important. Meeting the relatives and next of kin, especially when there's a major morbidity. Like you say, you should actually do it together with the surgeon because we don't trust them and they don't trust us. You don't know what they really say. For example, they might turn around and say that it's all caused by anesthesia, all the anesthetist's fault and things like that. So it's good that two of you actually, at least during the acute phase, see the next of kin together. Okay, explain it, give a very common, just one explanation and not many versions to confuse people. Okay, and of course follow up after the major crisis. For example, if the patient has had anaphylaxis but luckily the patient survives, then you have to actually follow up and make sure that the patient goes for all these allergy testing and make sure that the patient has got medic alert bracelets and things like that, and have a sort of plan, or difficult airway, things like that. So you actually need to follow up and document. And like I said, if unfortunately on-table death occurs, then you might want to talk about your debriefing for not only the anesthetist but the assistants, the people around, especially if it's an unexpected death, like it can be very traumatic, right? If somebody who's already ASA 5E, then everybody tend to accept that situation. But let's say if the ASA 1 patient coming in, ASA 1 mother coming in with amniotic fluid embolism and die in front of you, that's very traumatic, and you really have to actually have a period of debriefing and just to take stock of the situation. So those are the things. I think all you need to know is the first bit that I have. That's the framework for you to answer. The rest of it are just to tambah everything. So I have all these few slides is basically what I elaborate upon the first slide. So all these things you can read. Again, I have these things for you in the thumb drive, so you can actually read through all these things and see what it's all about. Okay, so further actions and communicate with the surgeon and things like that. Arrange for further management. Documentation is important, and follow up. So doesn't mean you send the patient to ICU and that's it. Let the ICU people take charge. The next day or in the afternoon, you should go back and see how the patient is doing in the ICU. Follow up and be involved in the subsequent care. So if you actually need to speak with the family, best done together with the surgeon and avoid different representation events. Otherwise, first thing, medical legally, you may be at risk, and secondly, you really don't want to confuse the relatives in a very difficult situation. Okay, so speaking to the relatives, basically you tell them the facts, not the speculations. What is possible, what possibly had happened, and what's the cause, and what you have done subsequently to try to avert the situation. So if it's unexpected death, most times the relatives are in shock. They cannot absorb the situation, the information. So you might have to go back at the later date and explain the whole thing all over again to them. Okay, and stress management for yourself, for your colleagues, and all that. You may have to do that. We are not machines. We cannot just carry on. And I have somebody, the patient is exsanguinating in front of us. And it's so difficult, and we actually almost lost the patient. And then while they were closing, the surgeon said, "Can we call the next case?" I mean, I don't know whether to laugh or cry at that time. You know, it's so insensitive and all that. So, but you know, we do need to have a period where we actually de-stress ourselves. So, informal debriefing, peer review, and things like that. I lost a patient through a failed intubation. It's a long story. I won't bore you with that. The next day, I went to my head of department and gave him the details of the situation. Asked him, "What would you have done?" You know, instead of what I have done. He said it's a difficult case. Under the situation, he would have done the same thing as I did. That made me feel so much better, because it's not because I was inexperienced, I was doing the wrong thing. Even a senior consultant actually agreed with what I have done. So that was a reaffirmation of the steps I've taken was not a mismanagement step. So that could actually help you to de-stress, help you to get back on your own footing again. Because when you are new, when you are junior, there are a lot of doubts in your mind. You don't know whether you are actually handling the situation correctly, whether you could have done better, whether, you know, if you change things, the patient would have survived. Those are the things that will plague your minds. So if you actually have got peer review and have got somebody to tell you, analyze with you each step of the way, what could have done or what you have done was correct, that is very good way to move forward. Okay, so learn from your mistakes, and also reassurance, like I said lah, from another colleague who have, who have been very good for you. Okay, am I making sense? Yeah, okay. I like this okay, I say from beginning, you do get asked in exam, but it's not often. So to a lot of people, they are sort of like, not important lah. But I think as an anesthesiologist, you should actually have all these things, because very soon some of you will be, clinical specialists already. You'll be managing cases, you'll be having your junior MOs and things like that. So the buck will stop at you lah. So you actually have to know all these steps in order to build yourself up as a good anesthetist lah. Okay, let's go back to the earlier questions. I think this one I've more or less answered already, isn't it? The critical incident, what constitute adverse event would probably be, what we discussed now, what causes the critical incidents that we went through, human factor, the equipment factor, the drug factor, and things like that. Illustrate with examples. You can just pull out any examples you want. And then the general processes that need to be followed after critical incidents would be what we've discussed just now. This question is a bit vague. I don't know where you actually should start. Whether you start from the very beginning, that means declare crisis, and all that, and go down, or you start when they say after the critical incidents. Is it after you already stabilized the patient, then you talk about discussing with, explaining to the patient's relatives, etc. My hazard is that because it's 4 marks, so they probably want you to start from the beginning. So it's sort of safer to start from the very beginning. That means declare crisis, etc., go down the line, like what I've listed down earlier on in the slide. So then you don't sort of like have the fear of omitting the essential things they're looking for. A lot of times, just be smart and look at the marks allocated. If it's 2 marks, probably not that much you have to write. But let's say if it's 4 marks, I think you have to write a lot more. Okay. But please don't be too smart to say that 2 marks means your answer has to be multiples of 2. Let's say 2 marks means you have to have the 4 list courses, must be 4 courses. It can be 5 or 6 or 7. Sometimes we give you not half mark, sometimes it's quarter mark, and things like that. So don't second guess the examiner. Just put down whatever you know. Okay. Now this one, the non-technical skills required. Do you know the answer? Still don't know. I went through all the thing like half an hour. So basically, they want you to talk about teamwork, talk about task management, talk about situation awareness, decision making, and application to clinical crisis. So these are basically what they wanted lah. So it's non-technical. That means you're not doing it, not intubating, not setting lines and things like that. But this again, it is like what we discussed just now. Okay, all these responses to the critical incidents. Now let's come to the more important one that is more relevant to you, crisis management in the exam. To me, it is the most tricky part of the question in the exam, but it's compulsory, both in the SAQ and the Viva. Because examiners want to throw these questions to see how you respond, okay? Basically, you separate the men from the boys or the women from the girls lah, okay? Testing your analytical skills, not just book knowledge. Because your clinical scenarios, management of diabetes, everybody knows. Management of difficult airway also everybody knows. But they want to throw in some crisis so as to see how you respond to them. So you have to be logical, you have to be realistic, you have to be organized, okay? Under those difficult situations, and you have to demonstrate safe anesthesia. I think the safety issue is the most important. You can be very brilliant, but let's say you have a very gung-ho approach in the exam, and the examiner feel that you're not safe. They're going to mark you right down, okay? Instead of a 10, they're going to give you a 3 so that you don't have a chance to pass at all. If you make a very fatal error in anything like airway management or crisis management. Okay, so you have to be safe at all costs. So usually it is, we don't straight away ask you, the patient is saturated, what are you going to do? Usually it comes as a clinical scenario. Let's say this patient comes in for dental extraction, and halfway through you find that saturation drops to 90%, what would you do? So sorry, it comes for dental extraction, how would you anesthetize the patient? So that's one part. And then 1 hour, 30 minutes after induction, the patient saturation comes to blah, blah, blah. How are you going to manage? So usually it's like 2-part question. The second part will be the crisis management. Okay? Same with Viva. They don't straight away, you just barely sit down, haven't warmed the seat already, they throw you one crisis question. That's rather cruel because they really throw you off, and you the rest of the half an hour is going to be like shaking already. Okay? Usually they ease you into the Viva, start you with the easy question first. When you get more confident, then they start throwing harder and harder questions. Okay? That's how we like to play with candidates. So if you're actually doing SAQ and you're doing Viva, it's slightly different approaches. Okay? SAQ, you can't interact with the examiner for obvious reasons. What you have is just a piece of paper in front of you. Okay? So it's your own interpretation and assumption. So in that case, you can't really get a cue from the examiner. You don't know what the examiner wants you to do. So yes, you have to cover everything. Okay. So whether you want to discuss worst case scenario versus best case scenario, probably is easier in a lot of cases, not all, in a lot of cases, to talk about worst case scenario. Let's say you've got this difficult airway like we discussed earlier on. It's probably easier for you to go right down the algorithm to CICB rather than to talk about, okay, this one done already, what would you do? But it really, I can't give you a sort of definite answer. It really depends on what kind of cases you're dealing with. In the Viva situation, it's a bit different because you have the examiner in front of you. So this is the same initial approach. You still do your SAQ type, your ABC still go the same. You listen, but the difference is that you listen to cues from the examiner. Sometimes the examiner asks you a question on bronchospasm. All they want to hear from you is the management of anaphylaxis. So you give the blah blah blah, and they say, okay, now you find that the patient has got urticaria on board as well. What would you do? So straight away, urticaria zoom to the other side and talk about anaphylaxis. Okay, so then they ask you about the management of anaphylaxis you give, and then it all goes the other way already. Okay, so there are sort of interaction with the examiner, and you go with the flow. Okay, listen to the cues from the examiner and answer the questions accordingly. You understand what I'm saying? Okay, right. So there is a delicate balance between your immediate resuscitation and also your evaluation and also the causes. Okay. When you have somebody who is actually desaturating right in front of you, you cannot be saying, I think the patient is having laryngeal edema and having respiratory depression, blah, blah, blah. First thing you would say is that attend the patient immediately, give 100% oxygen, the things that you do, okay? Rather than to give the causes, okay? So your immediate resuscitation has to come before anything else. And then when you actually done a fair bit of that, then you say, at the back of my mind, I'm thinking the possible causes could be this, and I would, my subsequent management will be targeted on these possible causes. So that's the way to actually handle this kind of situation. So what's next after you've actually done the initial bit already is to actually talk about specific management based on your provisional diagnosis, gauging the, like what we did just now, reassess the patient, see whether the patient responds to your therapy, reassess, rethink, subsequent management, just like what we've covered earlier on, okay? So now, I think, I hope I haven't actually put too much fear in you guys to think, wow, it's going to be difficult. Once I get the question, I'm going to peng san already, okay? It's not that difficult. Once you actually have got the practice enough and have got the hang of it, I think you don't have to be too afraid of it. Anyway, I told you it's everywhere, so you will come across it anyhow, anyway. So I think the best thing for you to do is to put yourself at the scenario and go from there. I think a lot of these things are not rare disorders. You would have come across it one way or another, okay? So think of yourself as a registrar anesthetizing this patient, and this patient developed this complication. What are you going to do? So make it real. Don't give us book knowledge. Sometimes, people talk about the darnest things in the exam, something that you've actually just read, it's just fine prints in some journal, and then you start quoting it as the first response. Then we start asking you, what do you know about this technique? Then you go, cannot answer already. So make it real, make it just common sense. So in the viva situation, tell the examiners what you usually do under the same circumstance. Do not second guess the examiner. You see the examiner's face, you think that he knows a lot about some obscure technique. So you start talking about that, and then he will squint at you and say, are you sure you want to do that under this circumstance? And then you have to go stand and say, no, I'm sorry. Then you talk about. So don't think about what the examiner wants you to say. Just say whatever you need to, and listen for hints along the way, okay? We are not so cruel to make you sink, see you drown, and don't give you a lifeline. Usually, if you're actually going way off, we're going to say, have you forgotten something? Do you want to actually look at the patient's, do you want to auscultate the lungs, for example? So things like that, we do tell you. So what can go wrong? You've got lots of things. This is not even a complete list, but basically you have got stuff like this that you have to handle. Again, go home, go through them one by one, and rehearse. It's very easy. It's not that difficult. You can actually rehearse these things, because all this like anaphylaxis, you know the management and things like that. You know how to actually handle it. Aspiration, you know how to handle it. So go through them. Look at the patients. So for example, patients at risk, and then the sort of the clinical features, management, things like that. It's actually not difficult. This is something you need to practice, okay? So the answer tips. So usually this exam the viva so usually you'll be stunned for a while when you actually thrown a question. So you can always just dilly-dally a bit. I will immediately assess the patient, or this patient's condition warrants immediate action, and then you think about what else to say. So always remember to resuscitate the patient first. Like I say, it's no point giving the underlying causes without actually talk about what you're going to do to the patient straight away. I think resuscitation also comes with your assessment as well. So I always put the C in front of ABCD, because you guys are all going to an ABC approach, but to me, C is important, especially when I talk about post-out patients. The consciousness of the patient is important. Let's say a patient is restless in the recovery bay. First thing I would want to do is actually assess his conscious level, maybe ask a question, see whether, Pachi, are you okay? What's the problem? And things like that. So if the patient actually can tell you that he is feel like wanting to pee and all that, you know the restlessness is due to full bladder, for example. Okay, so think about consciousness. Obviously, if a patient is drowsy or unconscious, then the C is not relevant. Then you of course go on to ABC. Okay, but if the patient is semi-conscious or conscious, then you can actually talk about conscious level. Your standard ABC plus a drug history, look at the anesthetic record, a drug chart and things like that, see what has been given and the duration and all those things. your initial assessment, and it's very important to actually talk about looking at the monitors. A lot of people just jump into ABC and doing the airway and the intubation without actually looking, because all these monitors, in the actual situation, it gives you the clues as to the underlying diagnosis, and in the exam, it makes the answer more complete. Okay, so your BP, either your invasive or your non-invasive BP monitor, your ECG for heart rate, rhythm, signs of myocardial ischemia, feel the pulse for a rate, volume, characteristic, regularity of the thing, look at SpO2, look at capnography, check to make sure there's no artifacts, and then other monitors if available. So I would actually put this one quite high up on your list of to do or to answer situation, because let's give you an example. Let's say the patient has got bronchospasm. What's the cause of bronchospasm? It can be due to light anesthesia. In that case, the patient's BP and the heart rate will be high. It can be due to anaphylaxis. In that case, the patient may be, having a low BP and hypotension and things like that. So you actually have to look at the patient's vital signs to actually make your to complete your diagnosis. Okay. Then this is more for respiratory event. Let's say that bronchospasm again. Check the anesthetic machine, equipment, and breathing circuit and the patient. Be systematic. Don't jump from patient to the equipment to the circuit and things like that. I always find it's easier to rule out the mechanical causes first. So that means you actually, for me, my answer would be to actually have a quick glance at the anesthetic machine, check the circuit, including the connections, to make sure that there is no, compression or kinking of the circuit. If the patient is intubated, talk about the ETT itself, whether it is correctly situated, whether the patient is sort of at the correct level, or whether it's endobronchial, for example. Talk about the ETT cuff, whether it's overinflated. In that case, you might have a cuff herniation. Or scouted the patient's lungs, look for air entry, whether it's equal or whether it's just unilateral. Look for adventitious sounds like crepitations or bronchi. Rule out things like pneumothorax, whatever. So you actually make it very systematic from the patient's, from the circuit, from the anesthetic machine right to the patient. You can do it the other way around, so no problem, as long as you're actually systematic about it. Okay? And then the other thing would be to talk about surgical site. See what they are doing, the surgeons are doing, whether there's an arterial bleed, whether it's pool of blood, whether the assistant is retracting wrongly, so compressing on the IVC, for example, reducing on venous return. So it's always good to say you look at the situation as a whole. The next thing you do is to declare crisis, but be reasonable not the BP drop down to 90 by 60, you go in the call for crisis already. So we also look for reasonable people, not scaredy cats okay? So you have to be actually reasonable in your answer. So communicate with the surgeon, either they withhold surgery, assist with resuscitation, or make sure that they secure the hemostasis or make it faster, and things like that. And then assistant that we've discussed already, and responsibilities when you have got assistants. And then by now you should have your working diagnosis, so you can present your working diagnosis and things like that. Tell the examiner what's most likely cause, plus some differential diagnosis if it's not very clear cut. And be sensible, say the common things first, but do not omit the rare but life-threatening situations, because they do happen, and they are the ones that examiners will be looking out for. See whether you realize that this can be due to a rare situation. Okay, I'm the one who is very, very particular about bronchospasm. People answer me and say that the cause is bronchospasm, and I would always jump upon the poor candidate and say, what is the cause of bronchospasm? That's not a diagnosis. That's a clinical manifestation. Bronchospasm essentially means bronchoconstriction, isn't it? So you hear bronchi, you got increased airway pressures, and you got increased volume of breathing if the patient is breathing spontaneously. But what causes a bronchospasm? Okay, so you actually have to go through, the causes rather than give me a bronchospasm as a diagnosis. Okay, so what else? Specific therapy, resuscitation, surgical options. This is essentially what we've discussed, so I won't go through that. And always, if you actually in the Viva, if you reach the time when if you're still discussing this case, then you have to talk about your post-op management and things like that. Most times, if the examiner is happy with what you said intraoperatively, they'll switch to another topic already. So you might not even reach this. But in the SAQ, obviously, you're not interacting with the examiner, so you would hopefully you can come to this point where you include your post-op management as well. Everybody okay? You have got like levofloxacin. SM, so Karen Lim Seok Wan. Okay. So you got a situation where the end-tidal CO2 is high in this child.
First is to assess the patient, look at the monitors. Besides the end-tidal CO2 being 50, what is the saturation of the patient, what is the hemodynamics of the patient. And then is to find out what's the cause of the high end-tidal CO2. Maybe either from the machine itself, faulty machine, all the way to the circuit, or from the patient who is having bronchospasm or King ETT.
A King ETT, will it give you a high end-tidal CO2?
No, actually no.
Yeah.
Then after that, we'll check. Of course, go through my airway breathing and circulation. And also look at the temperature of the patient, because most likely this is my differential. I will have my differentials of malignant hyperthermia for this patient.
Why?
Because it's screen surgery. It's a young high-risk patient, which is a screen surgery, and there is under general anesthesia because in volatile agent involved.
Okay.
Then if it's because of malignant hyperthermia, then I will declare emergency, declare crisis, call for help, stop the sevoflurane first, and then if possible, once the help is there, ask them to bring a new GE machine without any volatile gas if it's possible, and new breathing circuit. Otherwise, provide 100% oxygen.
High gas flows.
Then start on TIVA, because to maintain anesthesia. But I have to be
You've declared crisis already, huh?
Yeah.
You have, okay.
Then and get someone to bring the dantrolene for management. So dantrolene, according to the protocol, according to the use the kilogram is 2 to 3 milligrams per kilo. Reassess back the patient, also cool the patient because it's high temperature, so I have to cool the patient with packing and also intravenous to make sure the temperature comes down, and also hyperventilate the patient to bring down the CO2. And then put, if possible, bring invasive monitoring, and look at the ABG to look for acidosis and also the electrolytes.
What are you looking for in the electrolytes?
Potassium, calcium, and also CK. Then subsequently, reassess patient and see whether this patient's hemodynamic stable or not.
Okay.
Then plan for whether to post-op to put the patient to a PICU and continue for the
Okay. So essentially, you've actually done the preliminary bit to sort of think about other possible diagnoses, but you launch fairly early into the management of MH crisis lah. Okay. So let's go to this one. So does it have to be MH?
No.
Not necessary, but you have to mention that fairly quickly, because it is something that is life-threatening and is high morbidity mortality if it's not diagnosed. So you can actually talk about other causes of increased end-tidal CO2, for example, hypoventilation. For example, I can't really think of many causes of increased end-tidal CO2 other than hypoventilation. Anybody else? Yeah, anything? Because all your circuit problems and all that, usually it will mean that if you king the circuit, the end-tidal waveform is one kind, and then if you've got bronchospasm, then it is, upstroke is affected and things like that. So very little that gives you a high, other than increased metabolic rate, isn't it, which is part of MH. So you're talking about thyroid crisis. Not really, isn't it? So you actually have got very little. Got any causes? Please let me know. Soda lime.
Exhausted.
Soda lime, no, what? You increase your FiCO2, isn't it, rather than the end-tidal CO2. What else?
Tinggi sangat kot.
Huh? Yeah lah, that's why I say thyroid crisis lah. In a 10-year-old child is a bit this thing lah. You can mention that is under increased metabolism lah. Okay, what else? Can't hear. Seizure. Seizure, how? I don't know lah. Patient paralyzed under GA and having seizure is probably a lot of EEG activities and all that. Do they actually present with increased end-tidal? I'm not sure. Endobronchial intubation, you probably see that the end-tidal CO2, the graph is a saddle kind of thing, rather than and they probably present with problems with oxygenation lah. So I mean, especially in the heat of the moment, you probably can't think of anything, but I think it's a good thing to mention that you want to rule out other causes before you actually start talking about MH and things like that. So okay, so all these things. So once you want to go into MH, then you talk about your other signs. Feel for the temperature. See that if you want, you put in a temperature probe to actually document the rise in temperature and other things. So you go into that, which I won't have time to go through. So you do have all this MH protocol and things like that. Okay, so all this acute phase, post-acute phase. In the exam, probably you won't reach the post-acute phase and all that. Okay, so you will probably be concentrating on the various various thing. My second question is actually on this patient coming in 2 years later with acute appendicitis for appendectomy under emergency. So how would you anesthetize this patient? This would be the clinical question that is not too difficult to answer. That is assuming the patient is MH lah. And the whole thing sounds as if the patient is MH. So let's just take it as MH lah. So what are the precautions? How would you anesthetize the patient? Oh, sorry. One thing I want to say is when you actually talk about MH, one of the first thing you have to mention dantrolene already. You started talking about the machine. You started talking about the other things, but dantrolene has to come out very fast. Okay, just like anaphylaxis, adrenaline has to come out very fast. Okay, so I must call name. Okay, just now I call you, so it should be UPM Chia Su Gate. Yeah. How would you anesthetize this patient coming in for appendix?
Preoperatively, I would like to assess the patient, take the routine anesthetic history for the patients and also the comorbid for the patients. On top of that, specifically, I will explain to the family member or the parents of the risk of possibility of malignant hyperthermia in this patient, and take the high risk consent. Then on top of that, I will prepare I will anesthetize the patient by preparing TIWA, totally avoid of the usage of the inhalational agent, then avoid the usage of the succinylmethanol as the triggering agent of the malignant hyperthermia. And on top of that, the malignant hyperthermia kit should be available in the OT. Then besides that, the GA machine should be totally new, clear of any inhalational agent of previous cases.
The MA comes to you and say, doktor tak ada lah mesin baru. Ini semua dah
New
dah
circuit.
pakai punya.
New circuit. Plus.
Flush for how long? Sorry?
10 minutes.
10 minutes only, yeah. Cannot lah, tak cukup lah. I can't remember. Who knows? 40 minutes. I thought it's more than an hour. No. 40. Okay. Just check and see. But you do actually, if you cannot get a new machine, you just flush the machine with high oxygen flows and things like that. Some people remove the vaporizer from the system. Just take off the vaporizer from the back bar. Yeah. Okay. But anyway, you would basically run a TIVA technique and also have your dantrolene standby. Pre-op dantrolene is no longer advocated. Last time you used to say you give the dantrolene and all that to the patient before op and all that. That's not advocated anymore. So you just have it standby and have a temperature monitoring. That one you have to mention, temperature monitoring, and of course your end-tidal CO2 should be there lah. So any indication of increase in the temperature or the increase in end-tidal CO2, you have to act upon it immediately. You can pad your answer by actually talking about whether the patient has been tested positive for MH even before you start talking about anesthetizing the patient. So whether all these tests have been done on the patient and whether its diagnosis has been established or not, because the question is very vague, isn't it? Okay, happy with this question? Can I go on? Next one. The number of questions we tackle depends on how your response time is. So if I'm just going to base upon the next half an hour. If you respond a bit slow, then you have less question. And this part I'm not giving you to in the slides, just to let you know. Okay. Otherwise, I run out of questions to ask my candidates. Susah. Okay. So next scenario: 50-year-old lady with BMI 40, scheduled for LAVH, laparoscopic assisted vaginal hysterectomy. She has infrequent asthmatic attacks on MDI, PRN. What are your perioperative concerns? This is a non-crisis question. So what are your perioperative concerns? Should be fairly easy. Let me ask somebody who is not sitting for exam yet. Yu Ching? Li Yu Ching? Not here. Alvin? Yeah, Alvin. What are your perioperative concerns? What happened? Oh, hantu.
My perioperative concern for the patient. First patient is a relatively young patient with BMI 40 and also
Thank you for saying 50-year-old is young. Yeah, I feel much better now. Yeah. So I'm just about 12 years older than young. It's fine.
So my perioperative concern is basically because patient is obese with BMI 40 and also polycontrolled asthma.
Okay.
So I will assess the patient clinically.
No. I'm not asking you what are you going to do. I'm asking you what are your concerns. So you tell me patient is obese. You tell me patient is got asthma. What else?
The other things is the nature of the surgery because it's a laparoscope assisted vaginal hysterectomy.
Yeah.
So probably there'll be a lot of gaseous distension, and then it will affect all the hemodynamic and also the positioning of the patient.
Okay. Okay.
It also will affect the hemodynamic of the patient.
Okay.
And because of the infrequent asthma attack, also concerned that operatively it might have developed into asthma attack inside of.
Okay. Okay. So when you actually asked about, there's no trick involved in this question, yeah? When you ask about perioperative concerns, most times it's just a problem related question. So you're just going to give the problems. You don't necessarily have to give the solution. You don't have to say, I would treat the asthma, I will optimize the patient, etc., etc., because that's not what is asked for. So in the SAQ, if you ask this kind of questions, if you write extra, you're not going to get extra points, okay? So I think you guys have been primed to do this kind of questions already. So it's problem based. Either you talk about patient surgery anesthesia, or you talk about time based. So it's pre-operative, intraoperative, post-operative. This kind of formula, I think everybody knows lah. So okay, so you just list that, just sort of elaborate on a few of the patient problems and the problems of laparoscopic surgery. Not really much of anesthesia. Maybe you can talk about things like pure NV, things related to the laparoscopic surgery itself. Okay, so and not really very much to elaborate. Okay, so obesity, asthma, gynae, laparoscopic surgery. Gynae laparoscopic surgery, obviously the patient will have to be in the lithotomy Trendelenburg position, so that will further impede the respiratory exchange and compromise the CVS and things like that lah. So which you can elaborate lah. So that's the first introductory question. So a GA relaxant intubation IPPV technique was carried out. She was put in lithotomy Trendelenburg position for surgery. During CO2 insufflation, the high airway pressure alarms was activated. PIP has reached 40 cm water. What is your subsequent management? So this is the crisis part. So Ahmad Shafwan, UM. Okay. So how would you manage a high airway pressure in this case?
I would assess and manage patient at the same time. I would inform the team, surgery and anesthetic team regarding the crisis. This is high airway pressure. Detect the causes of high peak airway pressure. Can be due to the incorrect ventilator setting, or it can be due to the kinking or obstruction of the ATT, or it can be endobronchial intubation, and also it can be due to the high insufflation pressure during the laparoscopic surgery. I will discuss with the surgeon to stop the surgery and check the pressure.
What pressure?
Abdominal pressure, the insufflation pressure. Then
How much would you allow?
usually about 12 to 15 centimeter water. Then I will have a quick glance at the monitor, see the saturations, hemodynamic stability, then manage the same time, give 100% oxygen, assess the patient auscultation, and reposition the patient. Can be in the neutral position.
That means instead of Trendelenburg position, you put the patient back to
In the neutral
level.
supine.
You're going to lower the legs lah.
Yes.
He still remains at lithotomy, but in the flat
position.
Okay.
I will assess the. I will try to identify the causes. It can be due to the pneumothorax.
Have you auscultated the lungs?
Yes, I mentioned I got the lungs.
Okay.
Endobronchial intubation, or it can be acute exacerbation of asthma.
Okay.
If then I will manage patient according to unsuspected. Let's say if it's acute exacerbation of asthma, I will immediately administer inhale beta 2 agonist, Ventolin. IV hydrocortisone, 100 to 100 mg stat.
How long would the hydrocort work? How long does it take to work?
It's not immediate.
if I'm not
So
mistaken.
it's probably not going to help very much. In the first place, you're not quite sure of the diagnosis. Lah.
Yes.
Okay. Yeah.
Then I would reassess the patient after my management whether the high airway pressure still resolved or not.
Okay, okay. So basically, from what I gather from you is that the few things that you did to address the issue. One is to give beta agonists in case the patient has got acute exacerbation asthma, plus or minus hydrocortisone. The second one is you make sure that the insufflation pressure is not too much, or you ask the surgeon to stop insufflating. Do you want them to let the air out, the CO2 out?
Yes.
Okay, it may help the situation. Third one, you flatten the patient so that you won't have a steep head down position. And then you sort of went through a little bit endobronchial intubation touch here, and then you talk about the circuit and things like that. Okay, that's the thing that we all face. I mean, is you are actually trying to answer, but it's not as systematic as it should be yet. Okay, so like I say, bronchospasm, I always emphasize this lah. Bronchospasm is not. So what I would do is, okay, one thing we all old farts, we like to talk about off the ventilator and hand ventilate and see whether how to assess the compliance and all that. You may or may want to do, but your examiner is probably not as old as me, but as old-fashioned as me. So it's one of the things that you can actually talk about. You glancing at the monitor is a must, like what you said. Okay, looking at the end-tidal CO2, looking at the SpO2, also looking at the ECG as well as the blood pressure, to see whether they are normal or whether they are abnormal and things like that. And checking the circuit lah. We already mentioned that from the machine end to the patient's end, including the ETT in case it's endobronchial. I think when you talk about listening to the lungs, you should mention things like what I said earlier on, whether there's equal air entry, whether there's adventitious sound. Jump upon, if you actually have bronchi, then you think about differential diagnosis from bronchospasm. Asthma is one thing, inadequate anesthesia is the other thing, anaphylaxis is another thing. When you talk about aspiration is the other thing. So there are actually many other causes, okay? And if you have got unequal air entry, one of the things is endobronchial, the other thing is probably pneumothorax. In this situation, it's probably not as likely because is the baru nak start insufflating, is it? Takkan you actually get your pneumothorax straight away and things like that lah. So you work on those diagnoses. I know it is a bit difficult for you, especially in the SAQ when you've got no cue, no guide and all that, how far to go into each diagnosis. So because like you actually, when you talk about inadequate acute exacerbation asthma, you start talking about beta agonists and things like that. So how far do you go? There's no clear-cut answer to your SAQ and your SAQ writing. For me, I would actually want to do something to actually emphasize something on base my answer more on the things that are life-threatening. So if it's anaphylaxis, I will put a bit more emphasis on the anaphylaxis part and write a little bit more about anaphylaxis, management and things like that. Like I say, in the Viva it's easy because the examiner can guide you as to which one you want to answer. But what we actually want to see is that you have a broad-based approach. You have to actually cover, the necessary, the common diagnosis that we are looking out for lah. Am I answering the question? Are you okay? All right, yeah. So, like anesthesia, acute exacerbation, anaphylaxis, aspiration, acute APO and etc. So these are the things that you actually have to mention in your answer. Okay, right. So elevated airway pressures and things like that, you have got all these different things. Like I say, the circuit, the airway, the patient, and what to do and things like that. Okay, so you have to think about all these things in your answer. Okay, let's go on to the next one. Am I okay with the previous one? You say for. Am I okay with this this question, the airway pressure question? You're okay, happy with that? It seems to be a fairly common kind of exam question, so that's why I need to go through. Okay, this 60-year-old man with intestinal obstruction coming in for emergency laparotomy, GA induced using fentanyl propofol, sucks, RSI, correct pressure. This is a simple case of aspiration law. Presence of fecal material at the back of the pharynx. What are your immediate measures? Too simple, don't want to answer. Can I skip? Subsequent measures. No need lah, huh? I skip lah, huh? Can ah? Can or not? Skip. Okay. So basically, positioning of the patient, whether you want to actually have the patient head down, head up, sideways, or whether you just leave the position as this. I think most of the time we actually, when you actually in the answer a lot of books they go and tell you head down, left lateral. It's not practical at all. I mean, where it is, it's very difficult to sort of flop, especially if the patient is like 80, 90 kilos. How are you going to turn the patient like this when you actually haven't even secured the airway? Okay, so the most is head down and maybe suction lah. Basically, suction is very important lah. And then this is fecal material, so you may have to proceed to bronchoscopy to what do you call it, to actually clean up the airway. In case the patient has aspirated, whether you use steroids, whether you use antibiotics. Those are the questions that the examiners will be looking out for when you're discussing issues on aspiration of the gastric contents and all that. Steroids, most times, it is, these two are controversial. Steroids, most times, you don't use it, but if it's fecal material, a lot of people, they actually advocate the use of it. And antibiotics, if you already have fecal material, then you actually should cover with anaerobes and all that. I know a lot of times, the earlier literature actually says you should wait for the CNS, but once you talk about fecal material, I think it's very clear cut that you actually have to cover. Okay, so next scenario, okay, 32-year-old Claudette 3 Para 2 at 34 weeks, non-placenta previa, comes with PV bleeding, estimated about 800 mils. Obstetrician asked for immediate emergency C-section, just makan 2 hours ago. Okay, so how would you anesthetize this patient? Where was I just now? Who did I ask? I asked Shafan, is it? Okay, so you SN. I waste a lot of time looking at name list. Okay, I want to ask the non-exam going. No Zahira? Are you around? Okay, so how would you anesthetize this patient? This is a bleeding placenta previa.
So this patient need emergency operation with a full stomach in an obstetric patient. So I would like to first before the operation, during the during the assessment of the patient, I will explain to the patient the risk of aspiration. Someone is an obstetric patient, is a high risk of aspiration and a full stomach. So I will this patient will go operation under GA because of the risk of bleeding with the placenta previa.
Don't know what type. Not given.
I will assess the patient if can avoid GA.
Nak GA ke tak nak GA sekarang?
I will discuss with surgeon.
Surgeon say mana-mana lah. Tak kisah.
If
dekat Ali.
already bleeding 800.
Dekat Ali. That's your problem.
If currently is the bleeding is stopped and the patient is hemorrhaging stable, I will try to avoid GA and proceed under regional because need to wait the risk of aspiration also.
Regional, what regional? Spinal, epidural, CSE.
I will proceed with CSE, combined spinal epidural.
takes time.
Because in view
Spinal
if
lah.
failed spinal or in view of long operation need for this patient, I can top up with epidural.
Okay.
But if unable to proceed with regional, if indicated under general anesthesia, I will proceed. I will the patient need to be given the gastric prophylaxis prior to operation. The IV Maxalon, ranitidine, and also the sodium
Even
citrate.
under regional pun you give, isn't it?
Yes,
It's a
yes.
routine. Yes. Okay.
And then we proceed with general anesthesia and induce with the rapid sequence induction.
Okay, so basically this question is asking you for your anesthetic technique, RA versus GA in a bleeding parturient with obviously full stomach lah. Okay, so you need to discuss this rather than the actual nitty-gritty of how to perform the GA or the regional anesthesia. And I think you actually need to mention in your pre-op assessment the airway assessment. I tak dengar, I missed out, but did you actually mention that you actually assess the patient's airway? Because that sort of swings you more to one side or the other. If the patient has got obviously difficult airway, you try your darnest possible not to induce anesthesia. But in this case, if the patient is still actively bleeding and if hemodynamically unstable, in the absence of a difficult airway, you have to take the chance and put in a GA for the patient lah. But that's not the main gist of the question. The question is you have opted for GA during laryngoscopy, unable to visualize epiglottis or the vocal cords. What would you do? So it comes back to our DAS failed airway, which I don't think I want to go through with you. Do you want me to go through with you? So this is basically what we are supposed to do: call for help, declare crisis, maintain oxygenation. So either you actually put in the SGA or you actually do your face mask. Most of the time you do the SGA lah, right? And then you go through the decision tree already lah. Okay, so you have got somebody to help you. You managed to put in a size 4 procedural alarm A. Surgery was allowed to proceed because the patient is bleeding, so you have to carry on with the surgery anyway. Intra-op blood loss is 2 liters and the patient has become hypotensive. How would you manage the situation? Again, this one doesn't require the where am I? I was USM, isn't it? So, Muhammad Arifuddin bin Abdul Hamid, are you here? Yeah. Okay. So how would you manage this obstetric bleed? Yes.
I will identify this as massive obstetric hemorrhage and I will declare crisis. So I will make sure that patient having, I will look at the. Okay, I will make sure that patient having at least 2 large bore granula. I'll send blood investigation, full blood count, coagulation profile, and make sure that patient already have and also group cross match of the blood. So and while waiting for that, I will.
God help you if you don't have group cross match available. It should be there in the OT waiting.
Okay. So while waiting
you ask for 4 pints, they give you 2 pints. That's the usual scenario.
Okay, so while waiting for the blood to be prepared, so I'll make sure that patient is given fluid resuscitations. So and I will transfuse the blood that's already available. But if I suspect that the bleeding is uncontrolled, so I will consider to activate the massive transfusion protocol in the hospital.
You should already. It's 2 liters, isn't it?
Yes.
You already would have activated even before that. Yep. Okay.
And I'll consider to give IV transaminase acid, 1 gram over 10 minutes and 1 gram over 8 hours. And then I will also.
I assume that you have given your uterotonic agents and things like that, isn't it?
Yes.
Yeah.
So and uterotonic agents at the same time we need to liaise with the surgeon. I mean regarding the blood control management that they manage that they encounter. So and from that, if let's say if the bleeding is uncontrolled, I think the surgical side might need to consider about the next step of with the bleeding or even proceed with the hysterectomy.
Okay. So I think obstetric hemorrhage is something that you're all quite well versed with it now, okay? So it's fairly straightforward. There are some crises that are difficult, some crises that are fairly straightforward, and this is one of the straightforward ones, okay? So declare crisis, call for help, more assistance, volume resuscitation with fluids, activate your MTP, set more lines if possible, uterotonic agents, types, and you need to sort of tell them exactly what you use, carbitocin, pitocin, tranexamic acid is a good agent to use, not as a uterotonic, but as as an agent for massive hemorrhage, management of coagulopathy, surgical management, Blanche, internal ligation, internal iliac artery ligation, hysterectomy, and all that. And also your endpoints are what kind of resuscitation endpoints are you looking for, and subsequent management. So that's fairly okay. Do I have time to do another one? Is Prof here? Huh? Prof Wang is outside. Maybe let's see. Last one, okay? Oh, the one this one already. The one this one. The one this one. This is about a child coming in with craniectomy. The one this one also. Yeah, the one this one. Okay, the one this one. This is about last. The one this one. I think the one this one also. Okay, let's do the exam question. 55-year-old man with 100 kilos, 125, laminectomy, outline anesthetic implications, and how would you... Let's not do the... Wow, 7 marks, so much. Let's talk about the B part, since we're talking about crisis management. This fat fella in a prone position, undergoing lumbar laminectomy, having oxygen saturation down to 88% and the airway pressure up to 40 cm water. How would you manage this problem? Why? 3 marks, so little, you have to write so much. Okay, so free for all, just anybody will answer, please. Hi, you still have to pick. Bima! Part B, just part B. Forget about part A.
Hello. I will first I will inform the surgeon as well and declare not declare crisis, but inform the surgeon and the team. So I looked into the monitor.
So, Mr. So and so, this is not a crisis, but just let you know.
Yeah. Not yet a crisis. Yeah. So the SpO2 is 88%. So I'll check again the SpO2 probe again, and the ventilator function, and increase the FiO2 to 100%. I'll try to auscultate the lungs, and
so you crawl under the drips and you auscultate the lungs, okay?
Yeah. Okay, increase the FiO2 and look at the other vital sign. Blood pressure. If the blood pressure is low, that also can be a potential cause for the SpO2 drop. And check with the surgeon regarding the surgical field and the blood loss during the site. And
he'll probably tell you the blood looks a bit bluish now. Tune in. Just 2 minutes. Sorry. Yeah. So now you got 2 examiners watching you. Just to tell you.
Okay. If on auscultation, if I find any risk of bronchospasm suspect, it could be secondary to acute exacerbation bronchial asthma, or patient having bronchospasm secondary to secretion, or can be due to anaphylaxis as well. So in that case, I will apply bronchodilators or increase the anesthesia, deepen the anesthesia. In case of patient is obese, it could be due to the abdominal compression, the position as well, causing a diaphragmatic splinting and reduced ventilator. So that would be cause of the SpO2 drop. So I will again check the position of the abdomen is free or not. Okay.
Which should have been checked earlier on, right? But anyway, this is something that you have to go through
I'm
when you
going
actually face
underneath the
the
drape
situation.
from chest to abdomen now. Underneath the drapes.
Sorry?
I'm under the drapes now, from the chest, auscultate, then go to the abdomen.
Okay,
Yeah.
okay. Yeah. All right. Anything else?
Other than that, okay. The tube. During the auscultation, I also look for, is it endobronchial as well?
Yeah.
The tube, the migration of the tube.
Yeah. If they give you the scenario with just the desaturation per se, then of course the other things will come into play lah. Things like accidental extubation or disconnection and all that. But obviously this one you can't apply those things because the airway pressure is there and is increased. So I would tend to think about your misplacement of tube like endobronchial intubation in improper positioning, the splinting of the diaphragm, etc., like what you've actually written. Maybe because there are not that many differential diagnoses and management, so they give you 3 marks here. So I think with that I have to end this session. Thank you very much for your attention.
I'm old already. Often you hear them saying that, isn't it? I'm old. Yeah, okay. I know operation very high risk. There's a chance that. But you say that you get cognitive dysfunction. Oh, they get very scared. Often when we don't communicate properly to them, they will say, I don't want to op. Can you imagine your cognitive function decline post-op? It's a horrible feeling. I know that because my father went for an operation. He was 88 years old, and post-op investigator group, our vision lines in that meeting. And we were told that we can use their slides for presentation. So I'm going to use their slides for presentation, but you can read in the article. And everything comes on, because I find that this is a more updated one, and published in 2017, and it's very simple to understand. If you read the AHA guideline, is it simple to understand? Wow, it's a whole chunk, isn't it? But this one, I'm just going to make it simple to understand, all right? These are a group of people, they come together, right? They form a committee. Usually, a group of experts have been invited. And because it's a Canadian guy, they invite their own Canadians there. But they must be expert. And they will get lots of study. Let's say they want to look at the topic of smoking cessation. They will get somebody to do all the search in the guideline, all the study method and everything. And they will make everyone read. And 2 people will summarize it and present it. And they'll get a voting. It must need 2/3 consensus. I've done this before when I was in Italy. We were doing for morbidity, mortality for intensive care. I'm not intensivist, but they invited me anyway. So and Dr. Yong was invited. She's a proper intensivist. And so this is how they come out with general consensus. And this guideline is also been vetted by the editor and also by their society president, Cardiac Society, Anesthesia Society. All right, so what we're going to do is we look at the introduction methods and target population. So we are going to say guidelines of perioperative cardiac risk assessment and management for patients undergoing non-cardiac surgery. I think to a certain extent, this morning and yesterday lecture, you have covered something, right? Yes or no? So do you want me to go through? If you don't want, I can stop now. Right, you say worldwide 200 million major non-cardiac surgery procedures are performed each year. And 1 into 20 suffer myocardial injury or myocardial infarction, cardiac arrest or death within 30 days. You know what is myocardial injury? What? Okay, somebody tell me. Okay, please. Yep. I better don't point. It's very rude to point. Just call name again. Asma Azize. Huh? Where? Put your hands up. Okay, tell me what is myocardial injury. Is myocardial injury important? Yes. Why?
Myocardial injury is include myocardial is any insult to the myocardium, which include ischemia and infarction, and also included the cardiac arrest.
Yeah, good. This term already, the cardiologists already know what is myocardial injury, but they didn't know that it applies to the non-cardiac patient coming for non-cardiac surgery. So I was involved in this study, the vision non-cardiac surgery. We published MINS in JAMA and Anesthesiology. Myocardial infarction is the end, right? It's bad, your cell died. Myocardial injury, you injured the cell. Some of them can revive. So there's a spectrum, you see. You don't want to get to the end. If you have myocardial injury, there's still hope to revive them. All right? They're based on troponin, a certain level of troponin, which I'll come to it in a minute, to assess myocardial injury. And it's very important because they predict mortality. So now, if you don't know myocardial injury occur means, when you walk into the exam hall, you're dead. Right? You have to know them. So perioperative cardiac complications, they account for 1/3 of perioperative deaths. So the Canadian expert felt that new guidelines are needed for this pre-op assessment and also how you manage this patient in non-cardiac surgery. So in this presentation, we will have 4 things: pre-op cardiac risk assessment, perioperative cardiac risk modification, how you modify them, and you monitor this patient after the op for cardiac events, and how you manage them if you have MINS or myocardial infarction. Population. These are adult patients undergoing major non-cardiac surgery, defined as they have to stay 1 day in the hospital, there's overnight, and only cardiovascular outcomes are considered in this presentation, and they all focus on high quality evidence in the literature. So, pre-op cardiac risk assessment. Like we already defined earlier on about the categories of surgery. Emergency, it's life-threatening, you have to go in. Urgent means you can wait for a while. All right, you can wait for 24 hours. For example, hip fracture. But having said hip fracture, you can wait. Yeah, you can wait. But we already published an article on hip fracture now. You have to operate within 6 hours. Yeah, it's published in Lancet yesterday. And yeah, 6 hours. But unfortunately, there's no difference in mortality. But there is a difference in morbidity. We take the patient 6 hours to theatre. Our MOs are fantastic. They help us to take in. And they've shown that it decreases what you call pain. What they discharge the patient 1 day earlier. They decrease urinary tract infection. They decrease post-operative cognitive defunction and delirium. They decrease delirium. So there are 4 good morbidity they have decreased, but no difference in mortality and morbidity. 90 days outcome, 90 days. And but in the subgroup of patients, we found that those with high troponin, they come in high troponin and they got ECG changes. But these are the group of patients you took them into theatre, operate them, they do better. Their mortality decrease. So this will be our next trial called the Hip Attack 2. Anybody wants to join the trial? Put up your hands. I'll recruit you as member. Fantastic. I got one now. Any more? So this will be the group of patients we will focus. All right? You take them in fast, 6 hours. Huh? So maybe it is good for another subgroup of patients. Surprising, isn't it? We believe that you got unstable, your ECG changes high troponin. You dare to take patient in? You won't dare. But they took the patient in, the Canadians, you know, and they found that having operated, their troponin level all came down, and the ECG better. I'm sure you have patient where you operate on them, massive blood loss, go to the ward. ECG changes, massive, troponin high. We follow some of our patients that went to the ward, and I call them, look, the troponin is high. Something is not wrong in the patient. Have you checked the hemoglobin? Then the physician went to check hemoglobin 3.5. So he said, come on, top up blood. So I frankly called the physician to go and top the blood out. And the ECG improved. Patient walked home. Fantastic, isn't it? This is called monitoring post-op, which we're going to come to it. Do you monitor patient post-op? Troponin? No. Right, we're going to learn this today. Okay, so we have semi-emergency and elective. So the good practice statement say that the guideline recommend for patients requiring emergency surgery, you go against delaying surgery for preoperative cardiac risk assessment. It's an emergency, you're going to die. You're not going to stop them and say, okay, I want to do this, I want to do it. You can't, isn't it? Like you have abdominal aneurysm leaking away. I want to do this, I want to do that. You fail your exam. You keep saying you want to do so much. You just want to take the blood, cross-match, 6 units and go to theater straight away. Don't do this, do that, and delay, all right? For patients requiring urgent or semi-urgent surgery, the committee, the guideline recommend only if, from the history and physical examiner, you suspect that they have severe obstructive intracardiac abnormality or like tight aortic stenosis, severe pulmonary hypertension, or unstable cardiovascular condition. For patients requiring elective non-cardiac surgery who are 45 years age and older, or 18 to 44 years with non-significant cardiovascular disease, the committee recommend pre-op cardiac risk assessment. Now, I put the asterisk cardiovascular disease, all these things, okay? You can read it yourself. Now, risk communication is very important, like I say, ethically requires to be accurate and to apprise patients about benefits and risks of surgery. You have to be accurate. Like I say, they then did this TAHA in 2002, did a survey on 104 general internists, and they show the marked variation in definition of low, moderate, high risk peri-op complication. Everybody say differently. So that is very distressing, isn't it? You go to a surgeon, the surgeon say like that. You come to anesthesia, they say different thing. You go to the ward, the physician say different thing. Often it does happen. Does it happen? Your cardiac people will say different thing, you will say different thing, and the patient got confused in the end. No, we have to sing one tune. Patients have more accurate perception of risk presented as numbers rather than subjective words. Low, moderate, I rather want to know 6% of dying. Don't tell me you got low risk of dying. You have very high risk of dying. Unless the patient really, really don't understand, but you should give them precisely. So the committee, the guideline recommend that there should be explicit communication of perioperative cardiac risk based on expected event rate among 100 patients or the range of risk consistent with 95% confidence interval of the estimate risk. So it is strong recommendation based on moderate quality evidence, right? Strong recommendation, communication, risk properly. Okay, now we're going to focus on cardiac risk assessment, looking at clinical risk score, functional capacity, and biomarkers. To a certain extent, we have already covered some of the clinical risk score. So the two risk score that I'm going to talk about is the RCRI and the NSQIP, National Surgical Quality Improvement Program risk score. Now, the RCRI, in this guideline they come out, they did a systematic review on over 792 patients. And this study was conducted by Falk in 2010, and on 24 study, they found that RCRI had moderate discrimination to predict major peri-op cardiac complication. That is good, isn't it? They are moderate discrimination. And this risk score, RCRI, has also undergone extensive external validation. Now, if you look at the NSQRI-P risk score, there are two of them, the MICA and the ACS. One is developed by Gupta in 2011, the other by Bumoro in 2013. They are based on very large database, very, very large. They show superior discrimination than RCRI, but they're likely to underestimate the risk. That's a disadvantage because a lot of their MIs, they're missing because they don't use troponin monitoring. If you don't use troponin monitoring, how do you know they have MI? Correct? Because a lot of times, do you complain of chest pain after the op? No. No. Already shown in the POISE data, POISE study. They don't complain chest pain because why? Why? Huh? Examiner will ask you, why? Patient don't complain. Why? Samuel, why? Their surgical pain, they're good. Often they're on opioids, isn't it? They mask it. And some of them are on a ventilator. They can't talk and tell you they have chest pain. Right, that's good. Excellent. So they miss a lot of the MIs. So no, and also they're not validated externally. So they do have their drawbacks. So what we recommend is to use RCRI. All right? Now, if you base on the meta-analysis, they're compounded. So this is the total RCRI. So if you see this is different from that one, but this is compute everything. So again, RCRI groups, you have a higher percentage of mortality is there. So the panel recommends when evaluating cardiac risk, we suggest clinicians to use the RCRI over the other available clinical risk prediction score. So you can tell examiner, what do you use? You say RCRI. Why? And then you can tell them, I don't use the one the surgeon used, right? But you must have valid reason. You just say, don't say surgeon use, you don't want to use. Okay? So valid. So conditional recommendation based on low quality evidence. However, the quality evidence low, but they do recommend the whole group. Now, this self-reported functional capacity, we have touched a little bit earlier on. Some groups, they recommend to assess the patient's self-reported functional to determine their metabolic equivalence to guide peri-op cardiac risk assessment. However, there are limited data to inform this issue. So, in 1990, Riley did a prospective cohort study on 600 patients underwent major non-cardiac surgery. They found that the self-reported functional capacity did not predict peri-op CVS complication with an odds ratio of 1.1, right? Did not predict. And in another study by Wickland, also a prospective study on 5,939 patients underwent major non-cardiac surgery, Mmed is not independently predictive of major peri-op cardiac complications. And also the data raised concern about observer bias in the estimation of the patient risk. And this is the biggest study that was published just last year, 2 years ago, in Lancet. So they have also said that subjective assessed functional capacity should not be used in peri-op risk evaluation, right? And they have asked to consider others like DASI assessment. So you can see, but we still use, isn't it? Right? But you use it, you record down. But they are not so, what I call, they are limited, all right? They are not precise. Huh? When examiner asks you, you will tell them. You know this already, is it? No, okay. So the panel say, given limitation of the evidence, the primary panel decided not to make recommendation on how to use this self-reported functional capacity to estimate perioperative cardiac risk. So you want to estimate cardiac risk, use the RCRI, all right? This one, you can record down. We record down in our notes. Huh? But they recommend that. Okay. Now, how about biomarkers? There are many biomarkers that can estimate risk. You use hemoglobin, the surgeon does that, very low hemoglobin, predictive of mortality. You can use troponin, but NT-proBNP and BNP, this is something I have been trying to champion for the last 2 years to introduce into a pre-op clinic. I have failed because I retired already, so I can't, but I pass it on to the younger generation like you people to go and champion that. All right? BNP is brain natriuretic peptides, and NT-proBNP is N-terminal fragment of proBNP. They release from the myocardium when you stretch them. Let's say you have heart failure, you get a stimuli, stretch them, or you got ischemic, they are being released. They are very good at to predict major cardiovascular events after non-cardiac surgery. I'm not selling for the company, bear that in mind, all right? I will tell you why we should start using this in our pre-op clinic now. Just to show you, this is the thing, the cleavage here. So you will have the NT-BNP, NT-proBNP, all right? They've been released. One of them disintegrate very fast, the cleavage very fast. So you have the BNP you can measure, or the NT-proBNP, depending what literature you read, all right? If you want to measure it later, then you have to measure the other parameters. Now, in 2004, Rosette published look at the individual data meta-analysis of 18 studies on 2,000 patients, all right, 2,179 patients, and they found that pre-op NT-proBNP or BNP measurements independently associated with death or non-myocardial infarction at 30 days. You see, the odds ratio is 3.40 and it's significant. The threshold associated with it, they come up with a threshold of 300 nanogram per ml per liter and BNP of more than 92. So that is the threshold when you determine, right? So you flag, I'll give you certain threshold that is important. Sorry, I keep having double slide because I try to delete, like I said, have to prepare it, and we were given a short time to prepare it. How come this one doesn't come in? Oh, okay, right. So this is the test result. If you have less than 300, your estimate risk is 4.9%. But if you have more than that, 21.8%. So sometimes in the context that somebody, and this is compared to the RCRI, it didn't come out, sorry. There's another, RCRI, sorry. Compared with the RCRI, if you add this, you improve your risk stratification. That means improve risk classification in 155 patient in 1,000 patient based on their risk category. Based on different risk category, you actually improve it. So you do your RCRI and you do this, it actually improves it. You improve your risk classification. So it is very useful. You don't have to send patient for echo anymore. Echo, right? You want to see tight aortic stenosis. Yes. Intracardiac lesion. Yes, you have to see valvular lesion. But to see whether their heart functioning good, you do this. Then you send echo, cost money, come back another day, cost patient money, cost patient time, right? Unless, like say, you got intracardiac lesion, you have to send to echo, right? There are very few indication now for echo. You must have heard our cardiologists going to the ward, what the hell you're referring this patient to me, to do echo? They scold you, isn't it? Do they? You don't, You're so good cardiologists. Our cardiologists scold us, isn't it? Why are you referring? No need to do. Then our anesthesiologist get mad, So I try to introduce this and then calm the anesthetist down. There are very few indications, I told my. Now, this is the latest study published actually early December by our group. I'm also involved in it. I don't want to praise myself, but it's good to know that I'm also involved. That's why I attended the meeting. Consider shared care management, consider daily troponin, and obtain an ECG in a PACU, right? If it's urgent, then you look at proceed to surgery, only undertake pre-op cardiac assessment if unstable, all right? Or suspect undiagnosed severe pulmonary hypertension, or you got obstructive cardiac lesion, like I said. Then you perform an echo on them, right? You've got to know. Then you proceed and again do all this monitoring for them. So easy, isn't it? They make life so easy. Then if it's elective surgery, you assess using RCRI, you do this, then you consider if you have 5% baseline risk score, you perform what? Well, I'm so anti-pro-BNP for you already. A drug company will be very happy. Then you order them, all right? Then if it's possibly more than 300, now we're going to change a bit of it because of recent publication, but I think we still hold this. And not available, you still have to monitor them, and no additional if it's less than 300. Okay? Right. Because this is really, there was at the presentation at the meeting, the professor presented on his father who had unstable angina, going to have total hip replacement or knee, I can't remember, but be significant. All right? So it's either here or there. If they don't cross the line, it's significant effect. Okay? And the size of the study. Then ultimately you get the diamond. The diamond. The diamond. All right? The pool estimate effect. So, good or not here? So what does that tell you? See, relative risk for early. So, significant difference, isn't it? You get more vomiting, isn't it? Favors control, favors treatment. Then, of course, you have to test whether all this study got a lot of heterogeneity or not, or publication bias or not. So, you have to look at I squared. I squared. That will tell you that. So, then, funnel plot. This will tell you whether publication bias. See, a lot of missing data here, right? So, in meta-analysis, when they produce this thing, first they show you that forest plot. What is this? You say, oh, this is a forest plot. So this is concerned meta-analysis. Then you say, what is meta-analysis? Then you tell them, what is systematic review? Then you say, how do you conduct your meta-analysis, right? So it's just different steps to conduct. After that, you perform your statistic meta-analysis. Then you get this result. So then you say, line of no effect. Then you say, oh, line of no effect. So all this significant, this one no significant. So you combine all the study, then you get the pool effect there. The diamond shows the pool effect. That's all they want to know. So, of course, heterogeneity, if very high heterogeneity, you got to explain in your article whether your study is good or not. So high, Heterogeneity means all the study are different. Their endpoint, the assessment become very different. If you're going to take different endpoint for assessment, like nausea, vomiting, or pain, you come down to the heterogeneity one, Like when we wrote the what you call tranexamic acid, what do you do? Tranexamic acid, topical, whether it reduce blood loss. But the problem is our blood loss, estimation can be hemoglobin, blood loss, the way you assess can be introduced heterogeneity. So we did this and found fantastic, very fantastic. But there are heterogeneity in certain things, so we have to start explaining.
graph that relate the chain of resistance to temperature. Like in this case, the principle is as the temperature goes down, if it goes up, resistance goes down. Sorry, temperature goes down, resistance goes down. So resistance high, temperature high. As resistance goes down, temperature become higher, right? Which means compared to platinum earlier, platinum is the opposite. As the resistance goes up, temperature goes up. So it come together. Temperature goes up, resistance goes up. But for thermistor, it's the opposite. Resistance goes down, temperature goes up. And it can measure up to 2-3 decimal. That's the importance of using thermistor. It can measure, say, for example, 37.0001. So 2-3 decimal. So slight change in body temperature it can detect. Let's say you want to measure cardiac output using PA catheter. Gold standard PA catheter to measure cardiac output. So you inject 10 ml of normal saline at room temperature. So when it enters the PA, in the pulmonary artery, the blood temperature is 37. You are injecting room temperature normal saline. So 23 plus 37. So the change will be maybe 36.90, it dropped very little. Blood temperature 37, saline 23. So it mixes, right, in the blood. One cycle, temperature at that particular point, maybe 36.970, 2 decimal, or 977. So you can pick up small change in the blood temperature by injecting normal saline at room temperature, right? So you can detect up to 2 or 3 decimal temperature change. That's the beauty of thermistor. So, okay. Now, thermocouple. This is used to measure your yogurt, for example. Yogurt, your beer, soya bean, or Coca-Cola. Because they manufacture this in the factory, right? Big factory, they have 10 gallon, 1,000 liter of Coca-Cola. To make it clean, no fungal growth, no bacterial, they have to keep it at certain temperature. Yogurt, for example. Okay? So they use thermocouple to measure, this is the temperature I want, this is the temperature I want for my yogurt. So it will be better, taste nicer. So they use thermocouple. You want a good beer, use thermocouple, not thermocouple. So because it is like a probe, they dip into this yogurt solution, temperature 23. Yeah, this is the one I want, temperature 23. Because it gives you an accurate measurement of the temperature of that yogurt, for example. Right? So just keep in mind, let's say you go to the volcanic area, you cannot use thermistor, you cannot use thermocouple. You use infrared temperature detector. So you are, say, 100 meters from the volcanic area. You get the infrared thermometer, you measure it. Temperature at that point, 1000 degrees Celsius, something like that. Right? So for our purposes, we use thermistor. So thermistor will determine our core body temperature. For example, you use your nasopharyngeal temperature probe, right? You put into the nasopharyngeal, or you can use TM temperature probe, or you use rectal temperature probe. You measure the core body temperature, indicate the temperature in the blood, in the core, in the blood, or in the brain. So this is core body temperature. Not the shell. The shell is just below the skin, at or below the skin. Deeper to that is the intermediate zone. So what we want to know is the core body temperature. Technically, we use thermistor temperature probe. Right? The one we use is thermistor. In the OT is thermistor, nasopharyngeal temperature probe using thermistor technique. Right. So thermistor is made from a small bit of heavy metal, for example, manganese, molybdenum. Right. This is not purely part 1, but if you know, it's better lah, in case they ask you in the exam. Okay. Now, when you're anesthetizing a small baby, neonates, elderly patient, so the temperature probe is important. So you use your thermistor nasopharyngeal temperature probe to monitor the body temperature, because if you expose the neonates elderly, you don't cover the body. So most of the time, the heat loss is by radiation. This is important. Radiation. Radiation is the main mechanism of heat loss in the exposed skin. That's why in neonates, infants, babies, you have to cover them to prevent hypothermia, because the heat loss is mainly by radiation. Second, convection. So to know exactly the amount of heat loss or the amount of body temperature, you use thermistor temperature probe. Ideally, let's say you put the thermistor temperature probe in the larynx, it's not 100% accurate, even though it is near to the brainstem, right? You put TM, also not 100% accurate. The best is to put the probe into the blood. How do you do it? Yeah, you use this floating temperature probe. You insert through the femoral vein. So when we do DHCA, deep hypothermic circulatory arrest, DHCA, which we have done two cases, I think. So we monitor the core body temperature by inserting a thermistor probe into the IVC to get the exact body temperature to keep the brain working, functioning. So we drop the body temperature up to 2018. Right? So you understand? So we put the thermistor probe into the IVC, measure the actual core body temperature, the temperature of the blood. So the thermistor is the best device to measure the core body temperature by inserting a temperature probe into the IVC via femoral vein. Then you are measuring the core body temperature, so you can drop the body temperature to 18 to protect the brain during deep hypothermic circulatory arrest for certain surgery. For example, aortic surgery, ascending aorta surgery, descending aorta, kan? Have you done that? You heard about that? This is what we want as a final year student. At least you have some idea lah. You cannot put the probe into the brain, kan? Nearest TM not as great as the one you put in the blood, right? Okay. No, I skip that one. Need hair? I will go to monitoring. Okay. This is important. The capnogram, basically, you measure the entire CO2 by using infrared analyzer, right? Which means this is your gas sample, gas sample sini masuk sini. So, sorry, ini sample, your expired gas goes this way into this chamber, right? This is reference chamber, this one sample chamber. You inject your CO2, your expired gas. CO2 will absorb infrared. This infrared source is from infrared light source coming from hot wire with certain frequency. So CO2 will absorb this certain frequency of infrared, resulting in reduced intensity of the infrared, which is detected here. So the amount of CO2 can be calculated lah. They get the ratio between sample chamber and reference chamber. Then the amount of CO2 is calculated simply because CO2 here will absorb infrared, and we measure the intensity of infrared. Then we compare with the reference. So this is the principle, so you have to know the principle only. Now, the one we are using in the OT is the side sampling system. Side stream sampling, which means there's a sample line from the Y-piece, right, to the CO2 module. So that's about how many meters? About that? 1 meter, about 1 meter. Sampling line attached to the Y-piece to the CO2 module in the machine, and it will analyze the CO2 content in that specific gas using infrared analyzer. So then, because of the long tubing, it get a slow response to get the capnograph. After you have intubated the patient, right, it takes maybe 30 seconds to get the waveform, right? So there's a slow response using this technique. If you use the mainstream of the capnograph, you get the response of CO2 immediately, right? So the mainstream, this is the mainstream. This mainstream, which means the CO2 analyzer is attached to the patient at the Y-piece. It's sitting there, right? So it will analyze there and there without using sampling line. So the response is within 5 seconds you get the CO2 waveform already. So this is the difference between side stream and central stream. Okay, mainstream, side stream and mainstream. So what you get from this technique, either side stream or mainstream, in terms of response, maybe we don't bother very much, because what is the difference between 5 seconds and 30 seconds, right? Patient won't die because of 30 seconds. So you can still get capnograph 30 seconds later compared to 5 seconds. So this is what you get. You have A, B, C, D, aspiration, inspiration. You should be able to draw this diagram and interpret the phases, right? It is not part 1, this is part 2 now. This is applied clinical measurement. So the measurement of the CO2, as you see from here, 0 CO2 because of inspiration. Let's say you get FiCO2 5 millimeter mercury, which means it's a rebreathing in the circuit, right? You have to change the soda lime, right? It should be 0. FiCO2 should be 0. So this is the entire CO2, mean of 40. How do you measure it? You measure it here. Not along this way, but at the end of expiration, before beginning of inspiration. So this is the measurement you take for entire CO2. If I were to draw this diagram, then I want you to point where is the entire CO2. You get it wrong, you come back in 6 months. Because this is very important, simple. Very simple, important. Have to, when you want to teach MO, you must know to give the right information. Now, there are few pictures or scenarios whereby CO2 waveform will have different pattern, which I think you should know. For example, like this, the capnograph waveform, as it goes down, become smaller, smaller, smaller. So what does it mean? It can be hypotension, right? It can be impending cardiac arrest, but it's not cardiac arrest. Impending cardiac arrest, hypotension, or hypovolemia. So you should be able to interpret diagram like this. So let's say the waveform is not typically square, right? It is bit slant. The takeoff is bit slow like that. You see in the monitor, in your display monitor. Then it means there is some airway obstruction. The patient is having difficulty to exhale the gas during expiration. So this is typical capnograph waveform in asthmatic or bronchospasm, macam tu. Right? Then you should be able to interpret. Kalau tak, you have to come back 6 months. Or you need another 6 months of training lah. So you lose how many thousand in 6 months? Yeah, a lot dah, tak money ah. Specialist allowed 1,500 times 6. So if tengok money, you think of passing the exam. Okay, this is typical waveform of impending cardiac arrest or maybe embolism. The trend is declining slowly, kan? So as the time goes, it becomes smaller. Eventually, kalau arrested, it flat lah. So normal capnograph, hyperventilation, right? Hypoventilation, CO2 more than 40, right? Bronchospasm I mentioned earlier, a bit slanted there, right? Okay, so these are the 3 typical waveform that you should be able to interpret. If I give you this diagram, you should interpret within 30 seconds, maybe less. Now, what about pulse oximeter? Pulse oximeter is a device that measures the oxygen saturation in the capillary blood. So, you know this diagram? Do you know the amount of oxyhemoglobin, deoxyhemoglobin absorption at different wavelength? So they calculated the differences between oxyhemoglobin, deoxyhemoglobin absorption at different wavelength, IR wavelength. You want to know the detail? I give you the detail, which is very complicated. All this formula, and then you get the actual SpO2 based on 2 formulas, right? What is the formulas? BS and Mmed. Okay. So you get the measurement of SpO2 97 and 91. So basically, this is the 2 diode, red and infrared, that a source for red and infrared radiation waveform at different wavelength. Then photocell to detect these 2 different infrared, red and infrared, and then electronic processes that based on these 2 formulas you get this arterial waveform. Now, this is the detail. Now, the limitation, these are the limitation that you get inaccurate SpO2 measurement. For example, carboxyhemoglobin, you get falsely high. For example, you use nail polish, weak signal, right? You might get low measurement. What else? Made hemoglobin, it can be low and high measurement. Weak arterial pulsation, low measurement. Or peripheral vasoconstriction, low measurement. So, okay. No. So it is a standard monitor, capnograph, and SpO2. In fact, now they have included in Australia the ultrasound. It's a standard device, machine that you use before cannulation ataupun block. So, pulse oximeter, capnograph, now ultrasound. Besides ECG and other thing lah. So ultrasound is a must. Without that, they can prosecute in case of complication. Let's say you are cannulating the IGV, internal jugular vein, or you're performing femoral nerve block without ultrasound and end up with hematoma or embolism. They sue you because you don't use ultrasound. So now it has come to that level. You cannot perform regional without ultrasound, except central block. Other block you must use ultrasound. Even cannulation, outline cannulation, you cannot simply poke like that. Ultrasound in Australia. So if thing happen, complication, they look at your nose. Do you use ultrasound? No. You go to the court. So now, same as measuring oxygen in the blood. Just now SpO2, you measure oxygen saturation in the capillary blood. Now you want to measure oxygen in the blood, you use ABG machine, right? So basically, you get the outline, arterial blood from your outline, sent to ABG machine. ABG will interpret, you get the PaO2 how much, right? From PaO2 you can calculate SpO2. So basically, the device they use is oxygen electrode. So you don't have to know detail. The oxygen electrode is also called Clark electrode or polarographic electrode. That's it. So if in the MCQ they ask you, the device, machine, equipment used to measure oxygen in the blood, this is the equipment. Right? If they ask you, what is the instrument, equipment used to measure oxygen in the gas mixture, fuel cell or galvanic cell. The detail is part 1. So you cannot forget your part 1. This is to measure oxygen in the blood, you use Clark electrode. If you want distinction, you write down this one, you get A+. You dapat Asmoron Award. Asmoron Award lah. This the detail lah. Now, let's say you want to measure certain gases in the gas mixture. You want to measure 20 gases in the gas mixture. You don't want to measure oxygen only, you want to measure oxygen, nitrogen, CO2, nitrous, carbon monoxide, everything in one measurement. You use mass spectrometer. This is used in the factory, right? So they want to measure 10 gases in one gas sample gas, kan? They want to know oxygen, nitrogen, N2O, what else? CO, sulfur, chlorine, everything. So they use mass spectrometer. We will measure multiple gases at one time. So we don't use for anesthetic because anesthetic we want to measure oxygen only or CO2 only. But this machine can measure 20 gases, 30 gases. So, but this is the machine you can use to measure oxygen. Besides fuel cell, you can use this. Right? For blood, Clark electrode. Remember that? Many of you confused between how do you measure oxygen in the blood, how do you measure oxygen in gas mixture. Almost all get confused. Then you lose 1 mark. 1 mark can make a big difference. This is the mass cell based on the molecular weight of the gas. The heavier the gas, there will be least deflection after the magnet. The lighter the gas, it will be most deflected. For example, this is mass spectrometer. Oxygen 32, molecular weight 32, CO2 44. So oxygen will be more deflected compared to nitrous oxide or CO2, right? So as simple as that. Then they calibrate lah. The set for oxygen is 32, CO2 44. Then they calibrate accordingly. So if the molecule of the gas fall at this spot, is belong to CO2 because molecular weight 44, oxygen 32. Then they get say 10 measurement, 20 measurement at the same setting, same time. But it's not meant for anesthesia. Okay, this is for ICU. ICU important because for ICU ventilator, they use many paramagnetic oxygen analyzer. So which means the FiO2 measured by the ventilator, Drager ke, Hamilton ke, whatever ventilator use, they use paramagnetic oxygen analyzer to measure the Fi oxygen delivered by you. So then they don't use fuel cell, they don't use mass spectrometer, they use paramagnetic oxygen analyzer based on the paramagnetic property of the gas. You just mentioned a paramagnetic oxygen analyzer for ICU ventilator. Okay lah. So detail maybe you draw this diagram, you are superhero lah. Okay, next now we tend to forget about important measurement, even though you have Sugammadeck, though you have Sugammadeck, but it's also important for you to measure the degree of relaxation by using gold standard equipment which is a nerve stimulator, right? Many of us have forgotten. But if you work in a small hospital, you are the specialist there, and you are given some money. You want to buy good GM machine, you good monitor, what else? Other things. Then ultrasound, yes, fine. This one only cost about 10,000. Example of nerve stimulator, sponsored by Tracurium. Fisher Fickle, okay. Now, this nerve stimulator, the different brand, but they are the same. Okay. Now you are thinking where to put the electrodes, kan? Which one positive, which one negative? It's always mingling in your mind. I don't know which one positive, proximal, distal. This is the one I show you. So positive is proximal. Positive, proximal, negative, distal. Remember, positive atas lah. Positive, negative. And then this is the sensor detector to detect the movement of the adductor pollicis muscle, the thumb, right? Okay. Right there. So, positive, negative. Merah always positive. You go to wiring pun merah positive, right? Positive, positive. Positive, negative. Then this one they put sensors in lah. Okay. One missing, dia tak ada sensors itu. Okay, now, how do you monitor? You have two modes lah. Number one is train of 4, count, TOFC, right? You count lah the number of twitches. 1, 2, 3, 4. Count the twitches. Number 2, you calculate the ratio. The fourth to number 1. The fourth count T4 against T1. So let's say no block. You must set the system before you give your relaxant, right? It's no point giving relaxant then you set up the system. No point. You must get the supramaximal current. Supramaximal current means the minimum current to stimulate the muscle. Maknanya you increase from 0, 1, 2, 3, 4 sampai to about 20, you get single twitch. That is the minimum current to initiate twitch movement of the thumb. Supramaximal. Normally about 20, depending on the skin layer lah. If you are thin, maybe 15 you get the twitch, right? Single twitch. If you're fat, maybe you need 40 because of skin resistance, right? So about 20, 25 average. So single twitch, you increase the current, got one twitch, there's supramaximal current. And then you change the knob from single to train of 4, count and ratio. No paralysis, you get 4. 1, 2, 3, 4. 4 count, eh? So no paralysis, no rock. You bagi simultaneum, let's say normal macam tu. Sat 4 count. Same height, but weaker count. So this is simultaneum, right? This is rocuronium. So this is before SAT. This is SAT given. This is no SAT, no rock. This is with rock. You get fade. You get rock, fade. Number 3, 1, 2. 1, 2, 3, 4. This is not complete paralysis in partial. So you count the number of twitches. 1, 2, 3, 4. Maknanya there's a fade. It's a fade phenomenon. Fade phenomenon for rocuronium. There's no fade phenomenon for simultaneum. There's no change in the height of the twitch if you don't give any muscle relaxation. Now, so now back to ratio. Ratio, you take twitch number 4 against twitch number 1 ratio. So when you look at the monitor, you get TOF count. How many count? Ratio. In order to get ratio, you must have 4 count. Because you are measuring the 4 against 1. So in order to get ratio, there must be 4 count. So ratio is important when to reverse. Right? When to reverse, you get TOFR. TOFR. count, you want to make sure he's completely paralyzed, right? Count 0, completely paralyzed, you can intubate. Count 0, you still get the ratio, you cannot intubate, right? You want to reverse with nestametropine, you must get the ratio, which means the count already 4, but ratio can be 0.95, can be 0.75, can be 6. You faham that? This is important. Many of you can answer this. Alright? Even though this is look like part 1, but in the final they do ask in the oral exam. Maybe one day they ask in the SQ. Okay. Now we have Sugamadek, yeah? Sugamadek. Okay. I just go a bit detailed. No block for count, right? Right, no block. Complete for same height lah. Moderate block count 1 or 0 to 1 moderate block. Kalau deep block memang 0 lah, complete 0 Right. This is just for intense relaxation. For certain surgery, you make sure count 0, PTC pun 0, right? Okay. This is the detail. Detail maybe I don't want to go through because there are other things that I want to tell you. Base. Oh, this is respiratory index monitoring. You are familiar with this diagram, kan? You know BIS monitor, and then you look at the score, 0 to 100. 100 mean patient is fully awake. 0 is dead. Flat EEG. So the principle of BIS is basically referring to the activity of the EEG. There are 4 EEG waveform. Anybody knows? Okay. Maybe I don't. Okay. Okay. So when we are awake, the BIS is 0, is 100%, 90 and above lah. Alright. So the activity is mainly due to beta, beta waveform, which means high amplitude, high frequency, right? So awake. When you want to perform or you want to provide MAC for colonoscopy, then you must have BIS around 70, 70, 60, moderate sedation, right? Now the anesthetic ratio in Malaysia, we finish 1 o'clock. 1 Okay. The ratio NS to population 1 in 30,000. 1 NS for 30 population, which is very low lah compared to Australia 1 to 10. 1 to 10,000. 1 to 10. Ours 1 to 30, Australia 1 to 10,000, UK 1 to 8,000, which means we still need anesthesiologists for the country, excluding MAC, because the physician surgeon want us to provide MAC. Therefore, the ratio has gone up to 140, 1 to 40,000. So anesthetist is no longer working in the OT ICU, but they want us to work in the endoscopic suite because they want us to provide MAC for colonoscopy, bronchoscopy, anything. So that's why this is important for us to know. So you must have BIS monitor when you're performing MAC in the endoscopic suite. Make sure you're giving the correct dose of remifentanil, methoxsalen, whatever lah. So intra-op, you want BIS around 40, 50, around here lah. So the waveform ni based on the EEG activity, remember? So this is the score that we want, and the placement though, I want to show you. Where's the placement though? This is straightforward lah, placement. The next one is the evoked potential. This is not new because we've been doing TIVA for neurosurgery, for cochlear transplant, and other orthopedic spinal cord surgery. So you have to know what is evoked potential. Okay. Basically, there are two types of evoked potential. I just want to simplify it. One, the sensory evoked potential. Number two, motor evoked potential. Right. So the best is to use both mode during orthopedic neurosurgery. You use sensory and motor. Now, the sensory is called SSEP. SSEP. Somatosensory evoked potential. It can be visual, auditory. These are sensory lah. BAAP, brainstem, auditory evoked potential. Boleh pakai. SSAP, sensory, SSAP. This SSAP. Okay, you can use BAAP or SSAP without MEP. Alright. So basically, you can also use motor MEP alone boleh, depending on the surgeon lah. Like orthopedic surgeon, UKM, they like to use MEP alone, not SSEP. Right? Okay, so basically what happened at the molecular level kan? Let's say you give local anesthetic, you block the nerve conduction at the level of depolarization, betul? You give relaxant, you block depolarization. There's no action potential, you block the nerve conduction, right? Okay. If you give, so you monitor the TOF count, TOF ratio lah, right? Because you give muscle relaxant, no action potential, no nerve conduction, you block nerve conduction. Therefore, you know the twitches, no twitches, there's no nerve conduction. You give local anesthetic. Sorry, I rephrase. Let's say you give muscle relaxant, it block the channel, ACH channel. They compete with ACH. There's no action potential, there's no depolarization, there's no nerve conduction. Okay? You give local anesthetic, it block the nerve conduction, right? By preventing action potential. Two different kan? Relaxant block the receptor, prevent action potential conduction. Local, they block the sodium channel receptor, right? A bit higher lah, up higher lah. Motor evoked potential, it prevent, we detect that process. We detect not the contraction or paralysis, detect at that molecular level, at the action potential, it detect there. It detect, which means it is more higher lah at the molecular level kan. So you detect the present absence of action potential. This is MEP lah. MEP is to detect the absence or presence of action potential. So in order to measure that, you have to put electrode near the cortex lah, cortex. So I don't know the detail lah, but by analyzing the waveform, they can detect whether there is action potential or no action potential. They detect. The form look like this example kan. So let's say there's an orthopedic surgeon, they cut the motor neuron. Before they cut, they touch lah. I want to cut or not? Is it vessel, nerve, tendon? So if they see the patient is not paralyzed, right? If there is a conduction, there is exponential, there is a nerve for the nerve. So they don't cut. If it is blood vessel, there's no exponential, they don't cut. So as simple as that. So that's why you need a technician to interpret the action potential punya waveform. We do not know kan. NS tak tahu. Cuma what is important for us, you must use SSEP, BAP or MAP or both or all three to make sure the patient is apneic, not paralyzed, apneic, and allow surgeon to operate. Therefore, they can know this is nerve, this is not nerve. If you give relaxant, everything will be paralyzed. The surgeon wouldn't know this is nerve, blood vessel, they cut. That's the reason why they use MEP, SSEP, or BAP during neurosurgery or orthopedic surgery. you can read this later. I give you the detail. I think before I just quickly go to ECG, I think you're straightforward, that issue. In terms of unipolar, bipolar. Unipolar referring to the chest lead, right? V1 to V6 unipolar. Bipolar referring to two leads. Lead 1, 2, 3, AVL, AVF, AVR, which means we are measuring two poles, right, left, apex. The vector this way, this way, this way. So it forms a triangle called interval triangle. So the vector, the direction of current, all towards the heart, this way, this way, this way, all towards the heart, apex of the heart. So the vector, so these three vectors meet together to form a interval triangle. So these three vectors are formed through bipolar leads, 1, 2, 3, AVL, AVF, AVR. Unipolar, many chest lead to indicate the surface activity of the heart. So, for example, V1, V2, mainly reflecting the anterior chamber of the heart, anterior surface of the heart. Right? 3, 4, septum, 5, 6, lateral. Right? Let's say you have anteroseptal infarct. Then V1 to V6 changes. There will be changes in V1, anteroseptal, extensive anteroseptal infarct. You get changes from V1 to V6, right? Which means affect the whole surface of the heart, anterior, septum, and lateral. Kalau 5, 6, lateral infarct. Anterior, V1, V2. So if patient is in cardiogenic shock, which means it affecting either anterolateral or lateral, right? Cardiogenic shock, normally anterolateral, the whole anterior septum, lateral, which means affect the LAD, the left main stem, right? If just lateral, patient might have APO, left ventricular failure, not in shock, maybe just hypotension. Kalau anterolateral, patient in cardiac shock, collapse, and they normally die before arrival to the hospital. Right. No. To know the characteristic of ST changes, so I think you all know. For example, the acute phase will not appear immediately. The acute phase of ST changes will appear maybe 5 hours later. The patient is already in shock. You have to do CPR. But ECG changes might be very minimum, ST elevation minimum, right? Maybe minimum 2-3 mm above or below. In fact, normally above. Ischemia below, more than 2 mm. But the full-blown changes will be seen 5 hours later with Q wave, which means the appearance of Q wave will be seen 5-6 hours later, not immediately. You may see ST elevation without Q, but 5 hours later, you get deep Q plus ST elevation. That indicate infarct. Infarct means the muscle, dead muscle. Dead muscle, there's no conduction. Therefore, that's why the ECG itu naik atas, then elevated, because there's no nerve conduction through the dead tissue, infarcted myocardium. So this is a typical acute infarct, ST elevation more than 2 mm, the full-blown, full evolved phase. And here you can see acute inferior, and inferior is diagnosed by using bipolar 2-3 AVF. Inferior, because inferior, you cannot detect or look the inferior surface of the heart by using trans echo. Tak boleh. You have to use transesophageal. So as it is not as important as anterior or anterolateral, therefore it is difficult to detect by using unipolar. If you use unipolar, you cannot detect inferior infarct because you need 12 lead. Or even modified CM5 pun you cannot detect inferior. CM5. CM5 kan? Modified CM5 you can detect anterolateral, anteroseptal, but inferior you have to use 12 lead ECG. After all, infrared infarct is not detrimental as anterolateral, causing acute left ventricular failure and shock. Infrared infarct may be detrimental if there is significant AV conduction abnormalities. For example, because infrared infarct ini basically area is supplied by RCA, which also supply the SNO. So those with infrared infarct, they will develop arrhythmia. Depending on the type, if develop severe SVT, they die lah. Unless you do defib kan. They normally don't die because you have time to treat. You got infrared infarct, you get ST no ST changes, but you minimum ST changes 2-3 AVF, but you get maybe AV block, a bit of SVT, tachycardia, more rhythm abnormalities. So infrared infarct is not as detrimental as anterolateral infarct causing cardiogenic shock. So they don't die there and there. Kan? You have time to treat lah arrhythmia. You give whatever you want, amiodarone ke anti-arrhythmic drug kan. Because the heart is not failing, that the rhythm is failing. Itu je infrared infarct. Okay. So in the exam, we can give you a piece of paper, piece of paper to interpret. For example, this is the piece of paper in front of you. During the medical evaluation, what is your diagnosis? Depend lah. Let's say, tell me what are the abnormalities in this ECG. Then you tell us one by one. If I ask you, what is your diagnosis? You go straight to AF. Don't waste time. PR interval, QRS, RR. This is AF. No. If you ask you, what is your diagnosis? Straight away AF. If you ask you describe this ECG, start one by one. Okay, this is the way. Okay, I skip. No, I think I skip this one. I just show you. Oh, echo. No echo. No echo. If you're doing cardiac anesthesia, you have to learn echo. Echo. Not only trans-echo but trans-esophageal, because echo is actually important for general anesthetists and ED physician nowadays. ED physician are learning echo now from us, from anesthesiology, from cardiac anesthetists. Not many cardiac NS are well off or know very well about echo, kan? General anesthetists, but cardiac they are very good. Cardiac anesthetists they learn. Some of them have diploma in echo. So actually not difficult to learn. This is a matter of like doing ultrasound for femoral block, ultrasound for internal jugular vein cannulation. The same. So what you see here, the chambers, transthoracic. You see just like doing block for sciatic nerve block. You see all layers. Even more difficult to get the sciatic nerve block. Why the nerve? This is straightforward. You put the ultrasound on the chest, transthoracic. Then you see all the chambers. Then you study the anatomy of the chambers. So, from echo, you can see the anatomy. You see right chambers, left chambers. RA, LA, RV, LV. Anatomy, kan? Then you know the valve. So, information you get from transesophageal, transthoracic or transesophageal, number one, anatomy, landmark, anatomy of the heart. Anatomy, chambers, RA, LA, RV, LV. You see the valve, right? Normal tak normal. You see the septum. Ada hole tak ada hole. ASD, VSD, valve, MS, all those things. Calcification, vegetation. All these are the anatomical landmark that you can see there and there. Right? There's no formula, no calculation. You see there and there. When they ask you, what are the information you can obtain from doing trans-echo? I see all the chambers. Number two, I can see the valve. I can see calcification, vegetation. I can see the septum, normal tak normal. I can see the contraction, the nature of contraction. These are direct measurement. Okay. So, example, this one. You see all these chambers, tak ada masalah. The bigger chambers, you see RA, right? Okay. This one the 3D, okay. Below ni 3D. So, detail. Okay. What I want to stress is about the anatomy, you know lah. But the contraction of the myocardium, this is a bit difficult to interpret. To know, you must do echo on the normal heart first. Then you can appreciate the muscle contraction. you do routine ni lah, you curi-curi ke apa-apa di ICU tu kan. You ask your specialist, or he's also learning doing echo, you do it. This is the nature. How does it look? RA, like this, contraction. You learn from the normal heart first, then you know the abnormal heart. So in normal heart, you get the normal contraction, right? Contraction. So, let's say you wouldn't know hypokinetic ataupun hypokinesia unless you know the normal contraction. You can appreciate. Hypokinesia means decrease in the myocardium contraction. There's a contraction normal actually. Any weaker contraction is called hypokinesia. Right? Hypokinesia. Alright. Let's say contraction normal like that. Abnormal, weaker, hypo. Kalau irregular contraction is not fibrillation, irregular. Not regular is called dyskinesia. Right? Irregular contraction is called dyskinesia. If the muscle is not contracting, say one part is contracting, the other part not, it's called akinesia. So these four terms you must know. Normal contraction, hypokinesia, dyskinesia, and akinesia. So you have to know the definition. And the best is if, well, I don't think we give you the video for echo to interpret, maybe too difficult, but we can show you, for example, like this. The piece of paper, I give it this to you, you tell me what are your findings. Of course, we erase this label lah. What is the, then you, basic anatomy of the heart, like that. You know. Right? Okay. If you use transesophageal, patient need to be sedated. You cannot do a transesophageal in a awake patient. He will bite. You have to give some sedation. The best under GA. So during CABG, patient is under GA, then we do transesophageal. We don't transferase tak boleh. So that's why during CABG we do transesophageal as a routine in our hospital. And then you know, and you can discuss with the surgeon about the cardiac status during the operation. Quickly, now, blood pressure. This is another important monitor that you have to know. Basically, you use NIBP, right? The principle of NIBP is oscillotonometry, right? Oscillotonometry or dynamic. You measure the blood pressure indirectly, and the measurement is accurate. Of course, you cannot compare with invasive technique, right? So basically, there are two cuffs. Inflating, deflating cuff, right? The one sensing cuff. When you're inflating, you're occluding the artery, brachial artery. Right? When you turn off, deflating, they're opening up the artery. So when you're inflating, occlude the artery, then it is and the sensing cuff will sense the oscillation, the movement of the arterial wall. Just before the blood flow, before before deflation. Maknanya you are measuring, you are detecting the oscillation of the arterial wall before you open up the brachial artery. So which means it is better than using using sphygmomanometer. That is, when you hear the sound, you listen. This is before the artery open up, you are detecting the oscillation from the arterial wall. So, and then you get the waveform of the blood pressure. In Japan, they use pina press. They don't use dynamic. They use pina press. They are detecting the blood pressure by putting a cuff on the finger. So they still use cuff, but they don't use oscillation, but they use infrared to detect the oscillation. Itu je beza dia kan. Tadi kalau ada Mmed, they ada sensor to detect oscillation directly. This one use infrared to detect the oscillation. That's why they use finger. No. More interesting is to measure the blood pressure by using invasive technique, right? So you must cannulate using ultrasound, make it routine, your routine work like possible, kan? To prevent complication, alright, to get the best result, and then you are able to interpret the waveform. Okay. Now, the reason for having a nice waveform, though, basically, is a resultant of many waveform generated by the arterial pulsation and waveform reflected back by the diaphragm, right? Maknanya blood flow, artery will generate waveform, right? Like that. Okay. Let's say this is artery lah, merah ni artery biru. This one arterial pulsation waveform. It hit the diaphragm will reflect back, it bounce back to create net waveform this way. So, which means diaphragm ni is flexible. So, it will create 1,000 waveform at any one time because heartbeat 70 beats per minute. So the resultant of the analysis, the final analysis resultant of the waveform is the one you have. This one lah, your normal arterial waveform. So normal, abnormal. So normal waveform you get nice arterial waveform. Maybe I have here. This one nice waveform, right? You get a nice waveform. But let's say this is the normal nice waveform. Let's say the waveform is like this, right? Number 3, the waveform is slurred, slurred, flattened. So the system is overdamp. Overdamp means the damping factor is almost 1. Lock, bubble, thing, right? This, okay. Let's say the system is a lot of spike like that. So the system is underdamped, which means DF almost 0 or maybe 0.1. So in case they ask you, this system is overdamped, the damping factor is 1. Slurred, clot, blood clot thinking, very floppy, soft tubing. The waveform is exaggerated. This is under reading, over reading. Maybe it's very stiff diaphragm, stiff tubing, right? The system is over reading, you get high systolic, high diastolic. You measure the blood pressure as you go down away from the heart, systolic higher, diastolic lower, right? Remember that? If I ask you to draw blood pressure taken from the radial artery, femoral, radial, if from dorsal pedis, you draw the diagram. And you give your reason why systolic is higher at the leg, in the leg, lower in the femoral, even lower in the radial. Okay. Next, I think this is the last slide about Swan-Ganz catheter monitoring. Okay. This is used to measure cardiac output. The gold standard of measuring cardiac output is by using PA catheter, right? Thermodilation technique. The anatomy you can see from here. Let's say X-ray. So this is the 3D punya diagram, 2D diagram. The placement of catheter. This one, volumen Swan-Ganz catheter. The tip is in the PA. This is the anatomical figure lah, picture of the Swan-Ganz catheter. Situ. And then from there you can measure the waveform. The first, Swan-Ganz catheter is made from special Teflon, where it tends to soften and float in the blood vessel. The moment you put into the blood stream, it becomes softened and tend to float automatically, right? So it goes to the RA, you get this CVP waveform, right? So you know what is ACV, XY, So as you go to the right ventricle, you get right ventricular waveform up to 0 to 30. So 30 to almost 0, right? Systolic 30, 25, 30. Okay. And and then the tip will go to the PA. So this is PA, right? You get a new waveform, CVP, RA, this is the value, right? And the PA, at that time, actually at this time, the moment you enter RV as RA, you open up the balloon, it will float, float to enter here, you get this, that it will float to flow the blood flow to the PA, you get PA pressure waveform. This is the pressure, 15, 25, 8 to 10. And then when it starts to the narrowest, smallest PA vessel, you get wedge pressure, PCW. So you cannot float the catheter for a long time, maybe 1 minute, then you deflate. If you keep deflating, because pulmonary infarct. So this is the limitation of Swan gas catheter to measure cardiac output, right? To measure cardiac output, you use the thermodilation technique, right? Thermodilation technique to measure cardiac output. So this is the gold standard of using measuring cardiac output by using thermodilation technique. PA catheter thermodilation technique to measure cardiac output. Okay. Now, this is the picture. Let's say I give you this piece of equipment on the table. You should be able to identify what are these lumen for. All this you must know, right? Standard. One of you will get it. Don't worry, you'll get it for sure. And then the placement too. Okay. Now, to get decision, you should know the principle of measuring cardiac output by using PA catheter thermodilation by knowing this Stewart-Hamilton formula. This is Stewart-Hamilton formula. Forgotten, Stewart-Hamilton. Basic physiology. So you know this formula, okay. You can become lecturer.
Okay, thank you.
This is the detail of thermodilation technique. Now, this is a gold standard of cardiac measurement. Pulmonary artery catheter thermodilation technique. And measurement is taken maybe 6 hourly. You cannot keep deflating the cuff, end up with pulmonary infarct. So you have to measure 6 hourly for early. So it's not helpful. You measure every 4 hours. In between, you do not know what's happening. So the best to measure is using a PICO. So PICO will measure the cardiac output beat to beat, right? The principle of PICO is like this. You put a CVP temperature tip CVP, the thermodilation temperature, the thermistor tip CVP catheter into the RA. So you have one set there. Thermistor tip CVP catheter, one as a reference. You measure one measurement, and then you put another long cannula into the femoral artery and analyze the arterial waveform, right? So the first cardiac output measurement using thermistor tip PA just for reference, only one measurement saja. The next, so this is used for reference to use for PICO, which will measure area under the arterial pulsation, area under the systolic pulsation. So this is the area of the cardiac output. So this is arterial pulsation. You measure this area under the curve is indicating the cardiac output. So this is called calculation beat to beat by contour analysis of cardiac output. So you are analyzing the area under the curve based on the Stewart-Hamilton to measure the cardiac output beat to beat. So this system is called PICO. Maybe I'll show you the. So you have one here, CVP, thermistor tip CVP satu, and then femoral artery. Also they have thermistor tip, and then you analyze the waveform ni. So analyze the waveform based on this formula. The formula actually is the Stewart-Hamilton, and then the detail of the formula, you get Asmoran Award lah, Rashdan Award. Who else? In whatever award, Danaras award. You know this formula, you get Danaras award. So actually you are analyzing the area under the curve, and based on the first measurement of CVP tadi tu, you measure this according to follow this formula, you get bit to bit cardiac output measurement, which means it is important for you to know the cardiac output bit to bit rather than 4 hourly using PA catheter. The detail, the formula, so everything is there. You go back and read. Okay. Now, the latest, basically you know, this is the flow track. Flow track, if you want to measure the blood pressure saja, systolic, diastolic, cardiac output, cardiac index, what else? So you don't have to put CVP catheter. You only measure the hemodynamic. So like here you can measure the cardiac index, stroke volume, not this one. Cardiac output. So cardiac index, cardiac output, stroke volume, you use radial artery cukup, right? But if you want to know the SVRI, SVO2, and SVO2 ni resistant CVP, then you put CVP. So basically flow track ni like Pico lah. It measure the area under the curve, area under arterial pulsation, because you have radial artery cannulation of femoral, kan? So you still analyze the area under the curve, and they have the formula, and then they get all these are calculated measurement. Calculated tau. It's not direct measurement like the gold standard PA catheter cardiac output measurement. This is calculated measurement based on the Stewart-Hamilton formula as well as this formula, right? So you get all those important parameters. If you put CVP, you are able to measure the SVO2, the resistance, SVR, PVR, SVR, plus the volumes, the lung volumes and blood volumes. This volume here, sini. So you press, you get the volume, which means it will tell you what to give, what not to give, what fluid to give, what drug to give. It's a guide lah. So it will come to like a one screen with 4 angles, no, four column. You choose. So that point is moving continuously. So you can use that as a guide. What fluid to be given? Let's say BP low, right? BP low, SVR low. For example, BP low, SVR low. Then they tell you what to give. BP low, maybe they tell you to give fluid, crystalloid, colloid. SVR low, maybe you need alpha 1 agonist, noradrenaline. This just guide you lah. So all this based on the analysis of the area under the curve. So based on the Stewart-Hamilton formula. So this is the latest technology, flow track, basically like Pico lah. But this is least invasive lah. Least invasive. Just outline, you get cardiac index, cardiac output, SVR, stroke volume, right? That's it. At least you know where you are. I encourage you to use this for certain cases, not everything lah. Maybe to learn it, you can use as normal patient, 1 or 2. After that, use for high risk cases. I think I stop here. Okay, thank you very much. Reaction, you can shout, you can jump, so it can be very alarming to us. No. If you open up this socket or plug, there will be 3 wires. You see 3 wires. Brown is active, live wire, brown, or red. And then blue neutral, green is earth. So you just remember these 3 color-coded wires lah. Brown, red, active, right? Blue neutral, green is earth. If you cut this cable, the electrical cable, you cut, you get three wires there. These are copper wires. Green earth, light brown, and neutral is blue. So they are insulated with special material to prevent current conduction in case of leak. So this male is a male. All are color coded. Basically, the cables are color coded. The pins are not color coded. The pins are made from metal. I just put the color coded to make it easier to understand. This a male pin, 3 pin. Female, this is 2 pin. 2 pin. So there are 3 pins and 2 pin. Majority of the equipment are 3 pin plug system. Smaller equipment they use 2 pin. Just another illustration. Active, neutral, earth. There's a small fuse there. So this is the wall socket. This is socket. Socket. Now, the earth is a very big reservoir for electrical charges. So anything goes, current, electric, it goes to the earth, be neutralized there. So most of the equipment are earth. Our equipment, big equipment, except handphone. They are, besides 3 wires, there are, third wire is the earth wire. So this is to conduct the excessive leak from the device to the earth and protect the operator or person. Okay, now the 3-pin plug is the common one for any equipment, but the 2-pin plug for smaller equipment. For example, the cable to charge handphone, 2 pin, right? Radio. So without earth, this 2 pin consists of active and light, active, light, and neutral, brown and blue. So without earth. So those equipment that use 2 pin are smaller, lighter equipment. If you look at the OT wall, there will be 3 different colors of socket, white, yellow, and red. The red, okay, this is sorry, okay. This one always lari lah. So this socket, earth, life, neutral. They put yellow. I do not know why it is yellow, right? The white is standard. So this is called single standard socket 3-pin plug system. The red one is the one that I use for emergency in case of electrical failure, right? Electrical failure, major electrical failure in the hospital. This one is still operating because the backup is from the electrical generator, right? So let's say the main power is cut off, failure, all the white plug socket are not functioning, but the red one will be functioning because the electrical supply is mainly from the generator, right? Petroleum generator. They use petrol to generate the machine and electricity. So they are color coded red. So we don't normally use this to use our equipment. We don't plug in our machine to this. This is for certain equipment, for example, halang machine, which cannot be failed at any time. Halang machine, or maybe ventilator, possible. So in case of a power failure in the hospital and your equipment is plugged to this red socket, your equipment is running. So halang machine, we use this. Hemodialysis, we use this. ECMO, we use this. Right? We cannot accept hemodialysis machine to stop because of electrical failure. So as for halang machine, right? Okay, or hemodialysis. So this is the cluster of socket. The cluster of socket, I took it from hospital UKM recovery room. they are nicely arranged. Kan? This is just for cosmetic reason, I think. Look nice. It is below the common gas outlet. That one, common gas outlet. It depends on the design of the hospital construction. This is another one, horizontal layout. Just now cluster. This is along the pendant. So up to you where you want to have that type of design. Now, the current we're having now are AC, alternating current, which means the current is electron, it move forward backwards. So this one AC current, the current flows to and fro, backwards, forward, at certain frequency. So we use just now 50 hertz, which means 50 times per second. Like that, 50 times, 50 to and fro, 50 times per second. So this means 50 hertz. Right? Okay. Now, DC current is mainly come from battery. Your dry battery, the everyday battery, national battery, all this battery. Like here, the battery here is DC, DC current. Okay. Most of the hospital we are using AC, houses, hospital, and other premises, AC. DC is used for your remote control, for example, remote control, and maybe minor equipment, small equipment. AC is more harmful, more dangerous. You touch AC current, you may die. You may get electrical shock and die. DC you can swallow, no issue. You swallow the battery, end up with gastric perforation.
Bijak sikit lah, bijak sikit. Okay lah. You can swallow battery is DC, so that's harmful. Okay, fine. Aduh.
Okay.
100 million more dangerous.
Now, whether the current is dangerous or not is depending on the voltage, the ampere or milliamp, as well as the frequency. Frequency will determine, for example, like surgical diatomy, which has up to 1 million hertz, which is not harmful to the person. It only calculate, but it doesn't cause electrical shock, which means the frequency of the current move forward backward will also determine the hazard or complication of the electricity. Okay, what about current density? Current density is also important because it may determine whether the area is burned or not burned, which means if one small area you pass through very high density of current, will focus there, it can cause burn. For example, diatomy plate, surgical diatomy plate, if you don't put in contact properly with the skin, it can cause burn because the current density will be focused in one small area, it can cause burn. That's why when you put diatomy plate, you have to put it properly, which means the whole plate should be covered, placed onto the skin nicely without area which are not in contact with skin. Okay. Number 3, the wet skin is more vulnerable to electrocution, which means wet skin has a lower resistance, we allow more current to go through. So that's why when we are in the OT, we prefer to have dry hands or wearing glove, right? Because dry hand, you're wearing glove, that will increase the resistance to current. So current will not flow easily when your hands are dry or you're wearing glove. So when you're doing procedure, beside cleanliness issue, you prevent current electrical hazard. That's why you use glove. Or if you want to touch any cable, you must touch with your dry hand, not wet hand. Now, if you remember your physics, an electrical law. This is Ohm's law, whereby the current is dependent on the voltage and resistance, right? So I equal to V over R, or V equal to IR. So as I mentioned here, the voltage is 240. Right? In Malaysia, the voltage we use 240, fixed 240. Right? In US, I think 200. Australia 240, UK 200, 240. Standard international voltage is 240 volt. If you look at this formula, I is current. A current is determined by the voltage over resistance. That V is constant. So the important parameter is the resistance. So basically resistance will determine the current that flow through the body. Remember the formula? A very simple mathematics, right? V is constant. So the I is dependent on the R. Just like your flow. Flow equal to blood pressure over resistance, right? So resistance will determine the current. And so the flow. If resistance 0, your flow equal to the pressure. So when you are checking the blood pressure in the OT, you are actually checking the cardiac output, assuming R is constant. So that, just like that. So here, V is constant, 240 volt. R varies. If you have higher resistance, current is low. That's why right hand has high resistance, the current is low. Right hand has low resistance, so the current will be high. You just follow the formula. Okay. Now this is the typical electrical flow in any equipment. Okay. Let's say this the power supply. This is from socket lah, wall socket ni. Socket. So power supply standard 240, frequency 50. Active, neutral, you have a toaster there. So you turn on the switch, the current will flow through this supply to the active wire cable. It goes to the toaster, the bread get toasted, get cooked, and then the current will go through the same amount of current will go to the toaster, back to the through the neutral, and back to the supply. So let's say I put in term of number, 10 electron going through here. Go to toaster, back to through neutral, back to the supply. So 10 coming in, 10 coming out. There's no leak in between active and neutral. Understand? Which means 10 going in, 10 going out. So the same amount of current in the life and same amount of current return through the neutral. Alright, so there is no leak. Alright, the amount of current going in, amount of current going out is the same. So it is a safe machine. You can use this machine. Okay. Let's say for a person who is touching the live wire, current here, live current, I'm touching the live wire, I may get electrocuted because the current will go through my body back to neutral, right? So my body may get burned depending on the resistance in my hand, right? Let's say my hand is dry, resistance is very high, so I'm okay. The current go through my body, I'm okay because my resistance is high. It returns through the neutral back to here. Okay, understand? Okay. For example, let's say the machine is faulty. Your ECG machine is faulty, your IBP machine faulty, even your JA machine display monitor is faulty. So, and I'm handling the monitor, right? Okay. The current going through live wire, active wire, go through the faulty machine. Let's say this is Dynamap or ECG or your monitor, faulty. It's not properly serviced. There's a leak there. So going in 10, for example, 10 through my body, goes back 8 to this leak go through the earth. Understand? Maknanya, going in 10, going back 8. The different 2 will go through the earth and back to the supply. So total 10 here, going back 8 through neutral, 2 through earth, back to the supply, still 10. But there's a 2 current of 2 is leaking through the earth, right? Understand? So this 2 ni can cause electrocution. If your hands are wet or wet. So this is what we don't want. So how do you know that the machine is faulty or not faulty? You have to check it regularly. So this is the job of the electrical technician or bioengineer. Yeah, very dangerous. Okay, I give you the example in terms of calculation. Okay, this is the calculation. It's very simple. Let's say the current from active supply to through active wire go through you. You touching it, or you touching the machine, and your hands are wet. And when the hands are wet, the resistance is very low, right? So the current will go through the lowest resistance, which is through your body, because your hands are wet. So this current will go through here. Maybe all the 10 will go through your body because your hands are wet. So you may get electrocuted because your hands are wet. Over here resistance is high, over here resistance is very low. So how much current can pass through or go through your body? Very simple. Say the voltage given fixed 240, the current, so the resistance in your hand is very low, 1000 ohms. So you divide 240 amp divide by 1000 ohm, 0.24 amp, which is 240 milliamp, and this can cause VF. You see the danger of having wet hands touching a faulty machine. That sometimes when you're touching the TV antenna, you get a bit of tingling. There's a current leak into the antenna, which is normal in any TV. In Japan TV, it's normal. It's small current leak. Even you touch with dry hand, it's normal. Bit sensation, it's normal. But if the leak is huge, and you are touching the equipment with wet hand, this can happen to you. This is fake 240 amp. You have wet hands, low resistance. The amount of current that go through your body, not to return through neutral, but through your body, because your body has a very low resistance. This is the amount of current that passing through to your body, 240, and this is good enough to cause VF. So you go like that. So be careful. That's why you make sure your hands are dry. When you handle the machine, make sure your hands are dry. Okay, let's say your hands are dry. Machine is faulty, the same machine is faulty. Ada leak kan? Maybe the wire is not properly connected, ada break kan? All wire, eaten by a rat ke whatever. Okay, so the same current going through your body, but your hands are dry, resistance is very high, 800. So 240 divided by 800, 0.003 amp, 300 microamp. You touch it, just a bit of tingling sensation. You survive. So handling equipment with dry hands is important. So never ever touch equipment with wet hand. Never ever in the OT. At home also. Let's say you are having your shower, hot shower in the bathroom. Before you touch the button, make sure your hands are dry. Then you have a shower. Not to have shower, then press the button. Make sure your hands are dry, then press the button for hot shower. After that, don't touch. Because if there's a leak there, you will be electrocuted. Understand? There were cases, right? So once a while, you must check your hot shower lah. There's a small button at the bottom. It's called ELCB. I'll show you later. you by pressing that, you are testing whether the machine is faulty or not faulty. That's why, as I said there, when you buy an equipment, you must check the instruction. That's important. Even for small handphone, you must read the instruction. Okay. Okay. This is the numbers or values that you must memorize lah. This has come up many times in the MCQ or BAQ about the amount of current that can cause hazard to human body. As I said, direct current flowing through your skin, 300 microamp, you got tingling sensation. It's nothing lah, tingling, you know, tingling, right? 500 microamp, slight pain, pain. 1 milliamp, 1000 amp, pain sensation. 3 milliamp, muscle contraction. Say 10 to 16, you cannot let go. This can happen, for example, during the flight, the lampu jatuh, the person is being electrocuted. Then you want to help him. You touch his body, you get electrocuted as well. Because you cannot let go. Let's say that person is struggling from the cable, and the current that flowing through his body is 10 milliamp. You want to help him. Your generous heart, okay, I will help you. You touch him. You get stuck and you cannot let go. And you die lah with him. That's why when you want to help a person who is being electrocuted, you must use something that has high resistance. Wood, high resistance. Not metal. Metal is a good conductance. Body, good conductance because we have electrolytes. We have current in our body. So you take a wood, then ask him to hold the wood and you pull him out. Don't use your hand. Okay. 20 milliamp respiratory paralysis. 100 to 200. This is direct contact. VF. As earlier on, the faulty machine, if the current is 100, you get VF. Be unconscious with VF. If you're playing football during raining seasons, thunderstorm, the current is very high. You get struck by the lightning, you're dead. Shock. This one. This is the current is very high. That's why when it's raining, thunderstorm, don't play football, don't play futsal. Futsal is indoor, kan? Football, or rugby, because you're struck by the lightning. That's it. Because the current is very high, up to 10 amp. No. So this is a simple diagram to show the current flow in the OT, for example. Power supply from your socket, left. That this is in the socket, this socket lah, socket ni. Right, socket. Socket there. Live, neutral, earth. Just remember these three. Live, active, neutral, earth. So the current goes this way. This is socket, Ini socket, ini socket. Ini terbalik. Sorry. From here, your equipment there. This is plug, ini plug, right? Ini plug, socket, right? So the supply this way, right? Return. So say 10, went back 10. You get functioning equipment lah. This is behind the wall lah. This one, this part is behind the wall lah. Behind the wall there are cables lah to the main supply. So you plug in your ECG, right? So the current come this way like this. You get functioning ECG machine, right? So inside this plug, inside the plug and socket, this is a plug with 3 points, socket with 3 female, plug with 3 male. Inside here, there's a 13 amp fuse. Inside here, inside this plug, ada 13 amp fuse, small fuse, right? Very small fuse. Is a protector. If the current is more than 13, it will blow off. It blow off. Let's say the current that going through here is more than 13 amp, it will blow off. Disconnect the supply lah. So normally the current that going through here is less than 13 M lah. 13 M is very powerful. So unless there's a current surge, for example, during thunderstorm, sometimes there is a current surge, kan? Then the current that going through here may be more than 13. It blow off the socket, socket and the socket. Okay. Now, in your house, I normally maintain my electrical circuit on my own. I do it on my own. I fix the fan, hot shower, light, this more. I do it on myself. But I don't have certificate for doing that. But but I know when I learn from my friends, electrician, how to fix all these electrical appliances, wires, lampu, light. So inside the house, there's a small panel. The panel, there are few fuse, panel fuse, and inside there's a circuit breaker. So basically, circuit breaker is a protection from you to get electrocuted. Circuit breaker is a device that prevent excessive current that can go through the machine. It is like a fuse, but it disconnect the supply. If let's say the maximum supply is 20, but the current going through the machine is 25, it will cut off. That is the function, circuit breaker. It protect excessive current that can go through the house, for example. So the amount of current will be set by the contractor. Okay. So let's say the equipment is faulty. Let's say your hot shower is faulty, or rice cooker is faulty. The current go through active, right, to your rice cooker. Rice cooker is faulty, so some of the current will be leaked through the earth. Some will return to the to neutral. So to the earth either this way or this way, doesn't matter. So let's say, as I said earlier, let's say the amount of current going through here 10, faulty machine, 2 going through here or here, the end return through here. So if you touch this machine, you get the effect. The amount depending on your hand, dry or wet. Now, let's go back to the practical scenario. This is the one I took it from the OT. I think the same OT everywhere. OT, this is a clock. Okay. If you look carefully, temperature is indicated there. 18 degrees Celsius. Is it 18? 18.3. Humidity. What is this? 36, 39. 36. It's very out. 36. So this I think this is 2 set of humidity and temperature measurement. So 18, 17. I think the 2 set just to compare. Humidity 39, 36. Okay. Ideally, for the main OT, ordinary OT, temperature 18, 20, adult OT. Humidity 50, 50 to 55. This is very dry, 36. So it's not good for your skin. You get cracked lips. Being here for one day, you got cracked lips, dry skin, so not good for the ladies. So you make sure your OT is 50, 55. I know you never check this, you never bother, right? About temperature and humidity, but it's important for you to know. Because let's say the humidity is 80, I won't start the case. I won't. Because it will cause infection. It will facilitate, or it will cause infection because the area is very wet, humid. That's the reason why you need optimum humidity 50, 55. 80 is very humid, you get infection. Right? You get SARS in the OT or Wuhan. So that's why make sure before start. I think last month, when was in UKM, no, in UITM, humidity was 85, I stopped the list until they rectify the reason why the humidity was very high. So it's not suitable for operation because it will invite infection. So you must, this is too dry, it's good. You don't get infection, but it's too dry. Then you need a lot of IV fluid, fluid to the patient, to you as well. You feel thirsty because it's very dry, you drink a lot. So it's not ideal. So this is what you see in the OT. Humidity, temperature, and then what else I show you? This one, the gases supply, right? Gases supply. Maybe I have another one after this. It's not there. I want to show you the other LIOM name. Never mind. I just continue. I will go back to that. Now, in the OT, they actually you classify equipment into three lah, basically. Kan? The class 1, satu class 1. Class 1 is divided into two. Class 1 CF, where the amount of current allowed to go through the body is very minimum, 10 microamp. This is the area where you are doing intracardiac procedure. For example, inserting CVP line, pacemaker, cardiac catheterization, or CABG, any procedure where you are in contact directly with the heart. So this procedure must be done in OT with class 1 CF, where the maximum current that can pass through the body is 10 microamp. So this is standard. Example, in CV lab, CABG OT, or any area where you are going to perform CVP insertion, pacemaker, angiogram, or all those things that related directly to the heart. So this is the area where you should use. Area with electrical supply belong to class 1 CF. The current allowed is 10 microamp. The symbol is this, symbol heart. So if you look at the monitor, they put this label, monitor equipment. At the back, you can see this label, which means this machine is belong to class 1. Class 1 CF, class 1. No. The other one, class 1, but is BF. Ini CF, ini BF, 1 juga. But the current is slightly higher, 100 microamp, right? 100 microamp. Both current, 10 microamp, 100 microamp can cause VF if it get contact directly to the heart. So this is just a classification, but you don't worry very much. But if you know, all cardiac procedure must be done in class 1. That's it. It's more than enough. Any cardiac procedure related to any cardiac procedure, you must do it in dedicated OT where the electrical supply is belong to class 1. The class 1 is further divided into two. This is the ideal, cardiac CAT, civil lab, CABG, pacemaker. This is the place, 1 CF. The other one, 1 BF, slightly higher than 1 CF, because the setting of this electrical classification is different. The 1 CF is more costly. Itu aja beza dia. And safer lah for cardiac procedures. This is less safer. You can, but less safer lah. You can still do it. But don't do cardiac procedure in class 1B. Earlier on, they class 1 CF, 1 BF, 1 class 1B. So class 1B is mainly for a bigger machine. Let's say hemodialysis machine. So there are areas for hemodialysis unit. It's not simply convert what into hemodialysis unit. Cannot. You don't do that. Cannot. There must be a specification whereby you can place your machine here and there. So you're not simply, I want to use machine using this socket. That's what, no, not like that. There must be a dedicated area for hemodialysis machine whereby the current leakage cannot be more than 500. So like that. Now, again, for heavy equipment, let's say X-ray, you cannot simply use X-ray cable, plug in here, you can't. Tak boleh, because the current is so small. It's not meant for X-ray, not meant for CT scan, for example, because they need more current, higher current. So, for those equipment which require higher current, this is the symbol. So you have to provide double insulated, double layers of insulation. So when you touch it, you are protected, yeah? Because let's say the cable for X-ray, a big cable, right? Very big, not like ordinary cable, big cable. You step it, you hold it, you're okay because the insulation are double. If they use one insulation, you get burned, you get electrocuted because the current is very high. So they use double layers of insulation to protect the operator, the radiographer, for example. Right? This is the symbol. Okay. The battery is straightforward. Okay. Now, as I mentioned earlier, microshock occurs when the current going through your body via the skin, right? So you need a bigger current to cause VF up to 100 milliamp, which means it's not easy to get electrocuted by touching all those faulty equipment, unless your hands are wet. If your hands are wet, then you may get electrocuted. Just remember in your mind, whenever you want to touch any equipment, your hands must be dry, or you wear gloves, right? We do not know whether this machine is faulty or not. We do not know. We assume the machine are okay, but we never know, okay? We never know. So as I said, 100 milliamp, 100 milliamp, you touch, it can cause tingling again, Sorry, 100 milliamp, this one 100 milliamp. This is 100 microamp, milliamp, 100 milliamp, there, VF, right? So, you don't get this amount of current to pass through your body, very unlikely unless your hands are wet. Itu saja. If your hands are dry, you are safe because the current I showed you earlier is very minimum. Right? Again, I want to show you again. If the hands are wet, this is the amount of current that passing through your body, 240, you get VF, right? So this is called microshock, because there is no direct contact to the heart. So you can get VF if the current is big enough passing through your body. That is about 100 milliamp. This is more than 100 milliamp. You get electrocution, and this type of electrocution is called microshock. Okay. Now, all right. Let's say you are ironing to make your baju beautiful, more elegant, and your iron is faulty, right? And the amount current that passing through your body 240, you can get electrocution. You can get VF on the spot because the current used by iron is very high, very high. So the machine iron is faulty, and the amount current leakage through the machine you're holding is 240 and above, you get VF straight away. So that's why when you are doing ironing, make sure the cables are intact. That black white strap, white strip, right? You must be intact. The cable should be intact. The microshock is different. It occurs when there's a direct contact to the heart. For example, the catheter, your CVP catheter, what else? Your pacemaker catheter, or when you are operating directly onto the heart, CABG, which means there's a direct contact with the heart, and there's a faulty machine, the current passing through the saline catheter, right? Or passing through the pacemaker cable, or passing through the to the knife or scalpel or artery, which is in contact with the myocardium, you get microshock. In other words, it's a direct contact. You have a current directly in contact with the heart. So this is microshock, which means the current required is very, very low. So it can happen. Let's say your CVP line is in the RA, right? The machine is faulty. The current will travel from the faulty machine to the saline field catheter. Saline is a good conductance. So if the current is 60 microamp passing through, going through from the machine, faulty machine, to CVP line, to the right atrium, he will end up with VF. That's why you have to be careful when you are doing cardiac procedure. You must do it in the class A, 1 CF. This is important, alright? So, but in our normal practice, we seldom see this because we assume machine okay, Muslim okay lah. We never know kan. Once a while, because of our unfortunate day, very unlucky, we end up with this unexpected detrimental event. Okay, example like this. The machine is faulty lah. The current leak is very little, say 100 microamp, but you are handling the heart. You are putting a CVP into the heart. So the small current, 100, for example, 100 microamp passing through the heart end up with VF. So example here, okay. Say the voltage 240 fixed, and then the resistance is very high, but there's a direct contact to the heart via the saline catheter or pacemaker cable, kan? Even though the resistance is high, but the amount of current to cause VF directly is very small, 300. So this is direct contact with the heart, you end up VF. If you touch with your hand, there's no direct contact with the heart, it's okay. Doesn't matter, just tingling. But this amount of current is in contact directly with the heart, you get VF. That's why CVP catheter, pacemaker cable, cardiac catheterization, right? CABG, they must be done in dedicated OT or area, and they have to make sure the equipment are perfect. That's why they check all these halal machine before they start. They check the all CV lab machine before they start. Pacemaker, they check everything because the small current can cause VF, unnecessary VF. So, okay. Now, how do you prevent all this hazard from occurring? Basically, there are three mechanisms to prevent this from occurring. Number one, I mentioned earlier, circuit breaker, like a fuse, a circuit breaker. Number two, ELCB, earth leakage covalence. Number three, LIM, or LIOM, LIOM or LIM. Let's one by one. This is the typical 1980s electrical supply, power supply to the house. Okay, 240 voltage, 240. Every return. The modern one is better lah, look beautiful, all electronic. So the Hertz 50, right? All right, 1974 manufacture date, right? This is rotating this to show the amount of current going through the house, rotating. So the voltage, the frequency, the current range 10 to 50, ownership LLN. This is the old monitor lah, old power supply monitor. This is the counting meter to indicate the amount of current you have used. Okay. Inside the switch box, the meter is outside. Next to the meter switch box, there are fuses, at different rate. This is the amount current that it allows 32, 20, 32, 10. So these are the fuse to indicate the current load. For example, over here one cable. So 1, 2, 3, 4, 6 cable example. This cable can stand up to 32 M. 32 M. You need 20. Let's say the current going through here is 50. This will get disconnected. because maximum current that can go through this fuse is 32. Now the current flow is 40, for example, you get disconnected. Trip, tuk, like that. Understand? So blackout lah. Blackout to the socket supplied by this fuse lah. That's why at home there are many fuse to different areas. One room maybe one fuse, one supply. Living room maybe you need a bigger 32. Kitchen maybe 20. Your bedroom maybe 10, right? Because in the living room you have a lot of things there, so you need more current. So let's say the current load maximum 32 amp. Suddenly a current surge of 40, which means this fuse will get disconnected for that particular area, living room saja lah. So this fuse actually they are actually the circuit breaker to protect the user from getting excessive current. Remember, understand? Okay. Over here, I show you. This is the main on and off. This is the circuit breaker, like basically. This circuit breaker. This is you push the knob up is on. This is on. So the current load 63 amp, right? So if the current load, the current surge more than 63 amp, it will get disconnected. So the maximum current that this machine, this monitor or fuse can accommodate is 63 amp maximum, right? Which means 63, for example, 63 going in, 63 going out. Or let's say 20 going in, 20 going out, it's okay. Right? 70 in, disconnected. Okay. Let's say going in 60, going out 58, trip. Because the trip there 100 milliamp, which means there's current different. Understand? Going in 60, going out 58. The 2 amp different will cause trip, which means disconnected. So that's another feature of safety feature, which means the current going in should be equal to the current going out. If there's a difference, it get disconnected. Okay? Okay. This is an example of circuit breaker. Okay. Now the circuit breaker, CB or fuse. Number 2, the ELCB. The second method of preventing electrical hazard is by using ELCB. Earth leakage core balance is normally used in non-cardiac OT. Now modern OTs, they use all class 1. All OTs, regardless cardiac, non-cardiac, all class 1. But older OT, they use ELCB, or at home, especially certain devices like hot shower, iron, electrical cooker, or those appliances, they use ELCB to protect the user. It works like this. Very simple. I make it simple for you. Don't worry. Okay. This is the hot shower using ELCB. This is Panasonic. So, over here, there's a knob at the bottom there. ELCB test, right? You on the machine, your red light there, red or green light on. So you press this button to test, which means the machine is okay. If you press, it doesn't sound the machine is not okay. Dangerous. You must test before you not to every time you test lah. I mean, once a while you test. Before you on, make sure your hands are dry lah. Then you on lah. Don't use wet hand to on and off. It's not safe lah, because we do not know whether this machine is faulty or not. Unless you test it regularly, once a week, once a month you test. Okay. So what happened in ELCB? Ideally, I said the current going in, say 10, going back must be 10. So there is no difference between live and neutral, kan? Masuk 10, keluar 10. There's no difference. If there's a difference between live and neutral, then it's not normal. right? It's not normal. Okay, it's not normal. I show you. Okay. Okay. Let's say the current going in 10. The current return 9. So difference of 1 milliamp kan. So that will disconnect the system automatically because the LCB it uses very little current difference though. The current difference more than 10 milliamp, very little, it will disconnect the system. As little as 10 milliamp difference between live and neutral, it will disconnect the system. Understand? Maknanya, let's say the oncoming current say 10, the return 9. The difference 1 amp. There is a big difference. It will detect as little as 10 milliamp. It will disconnect the system. That is to protect the user. So this is used in many appliances, including that hot shower. So it's good. Okay. Number 2, the fire's warranty some more. Okay. So the current going through the live wire to the electrical equipment, the amount should be equal. Which means the current in the live wire must be the same as the current in the neutral. So the amount of current going through L is equal to the amount of current returned through N. So there's no difference, which means the machine is safe, you are safe, right? Okay. Okay. Let's say the same system, the current going in, current going out, but the machine is faulty, right? So going in 10, going out 9.8, for example. The difference is 0.2 amp. So this system will be disconnected automatically. Okay, because 0.2 amp is big. Earlier on I mentioned it detects as little as 10 milliamp. Right? 1 amp is 1000 milliamp. Right? So this is a good mechanism to protect the user. Now in the OT, we don't use circuit breaker or ERCB to protect the patient. So we use those two plus LIM. Maknanya we combine these three method. But mainly in the OT, circuit breaker is the top priority there, the main, and then below it is LIM or LIOM. I show you the diagram. Basically, this is your heart lung machine, for example. This is the power supply. There's a isolation transformer which separate these two systems, right? There's no direct connection between supply and equipment, and these two are separated by a transformer called isolation transformer. So which means this circuit is 100% independent, right, from the supply. That's why they call it isolation transformer or line isolation system, LIS, or line isolation monitor. The same name like LIS, LIM, LIOM, the same. So how does it work? As I said, this circuit is isolated from the main supply, so you can touch lah. You touch is okay, no problem. You can touch a live wire, you are still alive. You touch the neutral wire, you're still alive. Okay, even though the machine is faulty. So, machine is faulty, it's okay because there's no direct connection between this electrical system and the supply. It's what I call isolation transformer. Right? But you cannot touch with both cable. You cannot touch live and neutral with two hands. So you complete the circuit. You get electrocuted. So I think it'd be ridiculous to hold all wires together, kan? You one by one lah.
One by.
Kan, you cannot hold 3 wires with one hand, cannot. You have to do one by, because the electrician when they do repair, they do one by one using the magic pen, the
Magic wand.
Okay. Now, the LIM, this is the one I want to show you. This is the OT, this is LIM. Can you see this? Wait, let me put okay, this one old one, okay. This is the LIM, LIOM, or LIS, the same. Over here, there is an indicator to show the current that is flowing to the OT, the current, up to maximum 5 M. I show you in the electronic device later. So if the current use is more than 5 M, it will give an alarm. Maknanya you are overusing, you are using more than 5 M at any time. So this one will blink lah, and alarm bunyi. This is the old one. The modern one is, it looks like this. I think you see this in the OT, kan? Okay, so this is the current, maximum current here, 3 M. They put 3 aja, 3, not 5. 3, the old one 3, 5. So this is the amount current, milliamp, that going through the machine you are using. All machine total only 1.8, tak banyak, kan? Maybe this is not cardiac lah. So if the current is more than 3, it will give an alarm, indicating you are using more than you expected. You are using more than 3 M, so be careful. Maybe you have to reduce, or you have to stop, or you use one by one lah. This is non-cardiac, cardiac more. So this is just a warning. It doesn't prevent electrocution. Just a warning. They're using more than you're supposed to use. You are supposed to use, let's say, 2, not more than 3 at any time. So this will tell you about the LIM, just an indicator that you shouldn't use more than this in that OT, right? Remember, because the current we're using, they are arranged in parallel, not in series, kan? In parallel. So you have 1, 1, 1, 1, total 1. Let's say you have 10 equipment, all in parallel. So one equipment use 1 amps. So 1, 1, 1, 10 still 1, because they are arranged in parallel, not in series. It's again same, 1.6. Okay. I think I stop there. I think I haven't finished. Now, I will give you the list of method how to prevent, or tips how to prevent electrocution later. Surgical diatomy, it won't cause electrocution or electrical hazard, because the voltage is 240, but the frequency is not 50. The frequency is up to 3 million hertz. As I said, if the current flow is very fast, up to 3 million hertz, it won't cause any harmful effect to the person. If you use 240, 50, you touch, you go, right? You touch it like fire. But if you use 240, frequency 3 million hertz, you touch, you smell, which means the amount of current that go through your body to cause harm is dependent on voltage, number 1, number 2, the frequency. Okay. So the principle of diatomy, there are 2, unipolar, bipolar. Unipolar is for cutting, for coagulation, because unipolar uses higher frequency than bipolar. Okay. So unipolar is meant for cutting, coagulation, both. The diagram is like this. Okay. Diatomy machine, high frequency current, 3 million hertz per second. This is the probe or electrode for cutting or coagulation. So there's high density current at the tip of the probe. You cut, you can cut, you calculate, the amount current will return to the diatomy plate. So this way, which means the circuit is complete. Machine, probe, skin, cut, coagulation. This is diatomy plate. You put it in the tire, for example, to disperse the current. and back to the neutral, back to normal. So this is called unipolar, whereby the circuit is complete. It goes from the machine to the probe, to the body, diathermy plate, back to the machine. It's a complete circuit. So this is called unipolar, meant for cutting coagulation. The important aspect here is here. This is important. Let's say your diathermy plate or dispersive plate you place in the tie is not in good contact, it can cause burn. Because the role function of this is to disperse the current. Disperse current to become less density current, it doesn't cause burn, and the current will return through here back to the supplier, power supply. So unipolar is meant for cutting and coagulation. For bipolar is only meant for coagulation. Bipolar, okay. Same, the current supply, high frequency current, 2,000 million, 3 million. This is the probe, right? The probe. And the current doesn't go through the body, through the plate, back to the power supply. It only goes from the supply, tip of the probe, then return through the neutral. So on this way. So the circuit is not complete because it doesn't go through the body fluid to the diathermy plate. So that's the difference between unipolar and bipolar. So in terms of frequency, I think this one need more higher frequency. So I just refresh. For cutting, you need less frequency, 1 or 2 million hertz. For coagulation, you need higher frequency up to 3 million. And the current does not pass through the body fluid to the diathermy plate back to the neutral wire or cable. Therefore, this bipolar is only meant for coagulation. So it's not strong enough to cut the tissue, skin or bone. So, which means surgery like neurosurgery, eye surgery, anything that you need, you don't have to cut, you can use bipolar. Right? Understand? So it's not as good as unipolar. Unipolar you can cut, you can coagulate. This one you can only use for coagulation because the current doesn't go through the body fluid and return to the machine, to the power. So, right? Okay. Now, what about surgical diathermy and pacemaker? So, now when the patient is having pacemaker, never ever use unipolar. Okay? Do I have the note here? Yeah. No. Okay. So never ever use unipolar diathermy when the patient is having any type of pacemaker. Doesn't matter, demand or fixed, right? If possible, try to avoid unipolar. You must use bipolar, which means if you use unipolar, the current will go through the body, through the heart, body back to the diathermy plate, right? So the pacemaker can get wrong information, wrong signal, additional signal, which come from the diathermy. So the pacemaker get two signals, one from the pacemaker side, one from the diathermy. So it may get confused. It may not function. So unipolar diathermy can affect the function of the pacemaker because the pacemaker may receive additional signal from the diathermy that it will interpret differently. That's why if you need to use unipolar in this type of patient having pacemaker, you must have a magnet, which means you convert the demand pacemaker into fixed. You fix the rate 70, for example. Whatever happen to the patient, the firing rate is still 70, which means you need a magnet. So you put a magnet over the pacemaker, convert the demand pacemaker. Nowadays all demand fixed, very rare. You convert the demand into fixed pacemaker, you set lah 70 ke 30, 70 ke 60. So the pacemaker will fire 70 beats per minute regardless you use unipolar ke bipolar, doesn't matter. The magnet is special magnet lah, special magnet. ordinary magnet, but it's designed for pacemaker. Put on the pacemaker lah. Then you get fixed rate. You can see the pacemaker tracing. Let's set 70 to 70 lah. 70. Regardless, you use unipolar, which means you can still use unipolar diatemy provided you put the magnet on the pacemaker. That number one. Let's say you don't trust this, or you're not very confident, you don't feel confident. What you can do, pacemaker is here, right? Like a surgery in the leg, right? So you put the diatemy in the leg here, surgery here, so the current won't go through the heart. So it is okay. Let's say you're operating on the knee, TKR for example. Pacemaker there, TKR here, put diatemy here, so you can use unipolar because the current will travel around here saja. Understand? Right? Or here it's okay. Let's say surgery in the right shoulder. You put diatemy where? A plate here. The current will flow this way or this way also. So a bit dangerous like kan. Let's say surgery is here. Pacemaker here. Even worse. Right? Pacemaker here. Surgery, whatever you cross, like surgery left leg, pacemaker here, and then the current will go through the heart. So surgery here, surgery here, heart pacemaker here, diatemy here, so it will complete the circuit. Tak boleh. Even here, you put diatemy plate here, still crossing the heart. You put diatemy plate here, even worse. Understand? Even worse. So if possible, in that case, you use a magnet. Let's say surgery left leg. Surgery right shoulder, diatemy left leg, right leg. Okay, still you need a magnet. Surgery left shoulder, diatemy plate, left leg is worse, right? Because it goes through here. So the best thing is, if you want to cut the tissue of bone, use a magnet. But for certain surgery like eye surgery, neuro, you don't need cutting diatemy. Can use coagulation. Okay. So before you decide to use unipolar bipolar, first thing to do is to contact with the pacemaker dealer. Make sure the pacemaker is, there are few conditions before you subject to diatemy. The status of the pacemaker lah. In fact, you can talk to them to convert by electronic means. Nowadays, you can convert electronically, because they use all this Wi-Fi, all those things. They can convert from demand to fixed, and then to keep it fixed, you have magnet standby. Okay, now these are the precautions for surgical diatemy. Number one, if possible, use bipolar for those with pacemaker. If you have to use unipolar, you have to use it in short bursts. Ataupun you use magnet. Okay. Which means you are converting the demand to fixed rate pacemaker. Okay. Now, finally, with all this, your ultimate aim is to prevent electrocution, right? To the operators, including the anesthetist or the surgeon or the MBS. Number one, all electrical equipment in the OT ICU you must inspect regularly, which means this is the job of biomedical engineer. So they have a regular timetable. They will inspect, examine, check all this equipment, say every 6 weeks. So that's the job. They have a small logbook to check the GE machine in terms of electrical function. Number two, you use electrical equipment that conform the electrical safety classification. So let's say you want in cardiac OT, you must use devices that conform to class 1 CF, for example, because you're dealing with the heart directly. So any procedure related to the heart, you must use equipment belong to that class 1 CF, class 1 CF for example, to minimize the risk of electrocution. Number 3, procedure must be done in appropriate designated area, yes. Number 3, all equipment must be which means try not to use 2-pin socket lah, 2-pin plug. You must use 3-pin plug where the third pin is earth. So all EE must be earth. The green cable wire from the machine to the earth. You must use good insulation for wires and casing. For example, this one is not, let's say it's a break in the insulator, don't apply tape. So you dispose, get a new cable, for example. Because this insulator provide high resistance to your wet skin. Even if my hands are wet, I'm touching this. In case of faulty machine, I'm okay because this insulator is very thick and has high resistance. So that's why all machine should be well insulated as well as the cable. Nowadays, the GM machine monitor ni, the casing is not metal, neither stainless steel. The casing is epoxy, which is non-conductance. So they don't allow current to go through that casing because casing plastic okay, epoxy okay, not metal. Metal are good conductance. So and more expensive. That's why all the equipment, all plastic, epoxy plastic. Because one of the reason they are cheaper and they are non-conductance to electricity. That to protect the user. Okay, the next one. Okay, you use those measures, circuit breaker, ELCB or limb. So in the exam, they don't ask you the detail of this device, how does it work. They only ask you MCQ or BAQ. The method of preventing electrocution include circuit breaker, true, limb, true, ELCB, true, tan, wrong, something like that. They're joking like limb is LIOM or this. And then do not place IV fluid on the top of any electrical equipment, which means don't put your drink IV fluid on the equipment. Never ever put your IV fluids on the equipment. We never know if there's a leak, water leak, saline leak that can conduct electricity in a faulty machine. Do not handle equipment with wet hands. This is important. Use dry hand, not wet hand. Do not cover your machine ventilation holes. So do not cover to make it beautiful. Don't cover the body of the or casing of the equipment. Never ever. Even your TV, don't cover the rear ventilation hole. Don't leave it open for air to move in and out freely. Do not push trolley extra machine over the cable. That can damage the cable. Do not use extension cable or plug. Never ever. But we are doing it every day. We shouldn't do that. I think it's our culture to use extension cable simply because we have a wrong design for OT. That's why you have a good design for your OT. You don't need cables. So you have to work out how many socket you want in that pendant. You have to work out before when you are constructing the OT to avoid using extension cable, right? So the electrical point should be on the pendant, not on the wall. Try to avoid the wall socket. Must be pendant, small. So everything comes from the top to down. Because there's a cable like this, I can simply step on it, all right? I can fall because of the cable. So it's not good. So do not use essence cable. It's very dangerous. There were cases, operator get electrocuted because of exposed wire in the damaged extension cable. They are lying on the floor. So this is one example, a bad example. Okay? Having one single, actually only one main socket now. The main socket is here. This is a main socket, the main socket here. In order to put more equipment, fan, computer, handphone, additional light or whatever, so you have 1, 2, 3, 4. Of course, this is in parallel arrangement. It doesn't cause extra current. But this is wrong. It's very dangerous. So one socket is meant for one equipment. This is the best. Not like this. It can be done because all are in series, but it's not safe. It's not safe. We never know it. Because when there are too many cables, there might be some faulty damage to the cable. Again, it's the same. Okay. Do not use damaged cable, plug or socket. Do not allow water to come near to the EE. Wear glove during handling intracardiac catheter. So glove has a high resistance. So when you're handling intracardiac or any procedure, please use glove. Okay, thank you. I think that's all. Any questions?